Hello, friends. How are you all doing out there? A very warm welcome to today's session. Is my voice audible to all of you? Can you all hear me? Good evening, Arshana.
Hello,
Thank you very much.
Assalamualaikum.
Walaikum assalam, Dr. Sabir. Thank you very much for joining in. Thank you very much. I started speaking now, Archana. That's why voice was there. How are you people doing? How had it been? A long, long gap on your request. Yes, Atya, Dua, Sujata. Lots of requests were there that we wanted.
Yeah.
I hope this
Assalamu
gap
alaikum.
was
It was
good.
very good.
Walaikum assalam. How are you doing? I hope everything is settled now. Lots of busy
Yeah,
days.
Fine, Dr. Sabir. Fine.
95% it's settled. It was very good to have a long gap.
Yeah, breathers are always good, and lots of congratulations on daughter's success, Dr. Atir. That's a big
Yeah.
achievement. Whatever we do, I always feel that whatever we have been doing now that the time is up, actually it is what we have to put in for our kids' effort. So that is the basic
Yeah.
thing which we have to achieve now. So
Yeah.
we
Thank
pray.
you very much. But I'm very happy because she did marvelously. She got all A's plus straight now. She is
Yeah,
highest in her whole school.
mashallah, mashallah. Now tell me, is she bright herself or is it your input? Which
We
type
always say it's my genes.
So is she type of a daughter who requires supervision, or is she like independent, like mom, I'm gonna do myself? Is she like which type of student she is?
She is very independent.
Okay. So that means that how much input do you think yours is, and how much percentage do you give yourself in her success?
All the things which I gave was till 7th or 8th grade. After that, she is just motivated, and I just linked everything to the studies, like any gift, any ease, anything she want to buy, any
Absolutely.
sort of anything she want is linked to her studies.
Yeah, so this is an incentive which we give to kids, and that is
Yeah.
very good. I would like to suggest everyone, see, whenever we link this to our kids, they know that this is important. And I always suggest, and I always give this advice to my kids as well, that see, whatever mommy or daddy are doing, they give you a platform. However, it is not that forever you're going to be entertained on this platform. So you have to be yourself as a successful man or a woman in life. So this is very
Yeah.
important. So they should
Yeah.
know that they have to stand on their own feet and they have to progress themselves. So very happy on this thing, and I'm
Thank
sure
you
that
very much.
she
I'm
would follow
highly
with you.
thankful for your appreciation. Thank you
And
very much, Satya.
we pray that for daughters always, the most important thing is that she has a beautiful fate. That is very important, and they have a long and healthy life. Kids, Ameen Sumami. All right. So let's
Thank you.
begin, friends. We have done the sexual and reproductive health. We have done early pregnancy care, and antenatal care was done as well. So today we are going to do the maternal medicine, and we'll see how it goes after the break. What you people had been doing and how the things worked for you guys. So reading carefully outside the cubicle. All the presenters, please be a fast reader. Every word is important. Take 1 minute for reading, and please take your at least 30 to 40 seconds to organize yourself. So the same suggestion from which I always start, just to give you a quick reminder so that it becomes absorbed in your brain and you know that this is how you have to proceed. Now, when we talk about the maternal medicine, remember that the topics are very vast. We've got so many things to cover, and if some alien station comes in exam, students, they get confused. So my suggestion for all of you is, go on the mute mode, friends. My suggestion for all of you is that it becomes very difficult if you people try to learn every topic separately. So remember that maternal medicine goes in the same sequence, like the same sequence of antenatal care. For example, in 2019, November, day 1, students rang me after the exam saying, ma'am, Graves' disease was an exam, and we did not read it in the last 3 to 4 months. So we were not sure about the propylthiouracil. We were not sure about the medications to be taken because we did not read them. So the composed students, they went fine. Why? Because they knew if the tiny points are missing even, the most important thing is that they know the pattern of the maternal medicine. So they took the station as introduction agenda, the information gathering. Doing the information gathering, after that, effects of the hyperthyroidism to the mom and the baby, then taking through the antenatal care, intrapartum, postpartum. Maybe somewhere in between applied clinical knowledge was short, but at least they knew how to take the station. So don't worry if some odd one out station comes in exam. At least you know the pattern of the maternal medicine. Just follow the pattern and you'll do great in the station. Just take this tip for maternal medicine. If some odd medical disorder comes in exam, don't worry. Have a composed attire during that discussion so that you handle the station well and go through the postpartum care and come back to today. So I could see that Group A was making the same algorithms as that of mine, and I was very happy on that. Now you people understand how we have to do a targeted study and reach the goal. Perfect. The topics which I have done blue, they are the ones which we are going to do today. Other than that, there are many topics in maternal medicine. Once you come back to the revision of the books, like my first batch is doing Get Through nowadays. So when you'll come back to the books, we'll complete the maternal medicine, of course. Diabetes, thyroid, the bipolar disorder. We will do the, okay, so we will do the other topics from this, and which are going to be the topics of chronic kidney disease, sickle cell disease, von Willebrand disease, and the Charcot-Marie tooth disease as well. The related patient information leaflets from maternal medicine are few, but all the diseases that are given in the NHS, even the Charcot-Marie that's provided in the NHS. So whenever you read some disorder, take out lines from the related patient information leaflet. Where lies the difference? In the maternal medicine basic template, remember that it starts in the same pattern, that is introduction. You make a good agenda for which we have already fixed the lines. We know our history of presenting illness is going to be 2. Number 1, she's pregnant. So please ask how had it been going up till now. Don't forget the blood group. It is your patient's safety. If you think that it's an ongoing healthy pregnancy, congratulate on a planned pregnancy. However, if you think that it's something which you are going to turn her to the termination of pregnancy, please avoid congratulating because you're going to take her towards the ending up of pregnancy. The second HOPI would be asking the history about the medical disorder. May that be diabetes, may that be cardiac, may that be renal problem. All right? You're going to ask about the obstetric history regarding if it's the first pregnancy or she had it earlier as well. Then you're going to ask about the smears only if she's a high-risk patient. Otherwise, skip smears in the pregnancy. Family history, surgical, drug, personal, social, mental health. In the management, the first part would be how it affects the mother and how it affects the baby, please. Don't forget this point. Start from this sequence. It is better for your time management. And when you take her through the antenatal care journey, you tell her those points which would make you avoid these complications to occur. Then antepartum, intrapartum, and postpartum care as well. And please come back to today. Don't end up at the breastfeeding. Don't end up at the contraception. If she has come to you at 18 weeks, come back to 18 weeks. If she has come to you at 20 weeks, please come back to 20 weeks. Don't end up at the contraception or breastfeeding or the postpartum care. Always make a habit of coming back to today, where she has to take the message back home and when she has to come back to you again. Am I clear? This is a mistake which students make. Am I clear? That after postpartum, please come back to the gestation she has presented to you with. Only Archana has a message in the chat box. Am I clear, everyone? Please be active in the chat box so that I get input from your side as well. Thank you very much, Dipti. Thank you, my dear. Okay. Now, what is the difference between preconceptional template? Now, when we talk about, thank you, Nadra. When we talk about the preconceptional template, the difference is that the beginning will be the same. That is introduction, agenda, history. You will start the history from the medical problem the way we did in the antenatal care or during the pregnancy. You will complete your entire template of obstetric, gynecology, medical, family, surgical, drug, social, and mental history. Now here comes a problem. Please listen to me very carefully. Thank you, Dr. Sabia. Thank you, Abir, my dear. The problem lies when you come to the preconceptional template. After information gathering, you start giving the preconceptional counseling. Then you tell about the medical disorder. Then you come to the antenatal, intrapartum, and postpartum care. And after that, you end your station. remember, whatever she is here for, that has to be her last 1 to 2 minutes talk, so that she ends up with a clear-cut understanding of her possession and her situation today, for which she has come to you for, right? I used to work a lot on this, that how we have to make our preconceptional station shorter. When I see others, and when I used to see my colleagues, or for that matter, even my students in the last 2 to 3 years, I used to always acknowledge this point, that they start the preconceptional counseling, they come to antenatal care, they do the intrapartum care, postpartum care, and then again come back to the folic acid and changes in medication in the end. So twice they have to do preconceptional counseling. So the wise way to do and handle this station in 10 minutes in exam is that introduction, agenda, information gathering, tell about the effects of that disorder to the mother and the fetus, right? Please take her through the pregnancy journey, antenatal, intrapartum, and postpartum in 1.5 minutes, important points only, and then speak a line. So let us now discuss what we have to plan for your time period before pregnancy. Tell her about the folic acid if she requires, starting now, whether it's a 400 microgram or a high dose. If it's high dose, always mention it's a high dose. It's your patient's safety. If she requires some change in medication, refer her to the specialist who is concerned for dealing her pregnancy. Avoid her to suggest her to avoid smoking, alcohol, check her rubella immunity, or else give her immunization, vaccination. Tell her about all the results of the smear checking, healthy diet, lifestyle, and ensure that she understands this fact. So, Anne, we have agreed that you may continue to use contraception until a review by your doctor looking after your condition, and you start using folic acid today. Once you're pregnant, I would suggest that you let your GP know so that we can make an arrangement to book your pregnancy early, and we start looking after your pregnancy from the very beginning. Thank you for speaking to me. So the ending should be, if she's in a healthy shape of health, yes, allow her to get pregnant. But generally in the preconceptional counseling, either her HbA1c is deranged, or she's taking some teratogenic medicine, so you need to give her a little more time for the contraception to continue. So this is the aim of the preconceptional counseling. They want to say, they don't give you a healthy patient or a fit patient for which you give a green signal for her to get pregnant. They give you some sort of complication for which you have to suggest her to continue contraception a little more. All right. So my suggestion is, go to the effects of the mother and the baby first, take her through the antenatal, intrapartum, and postnatal, and end up at the preconceptional counseling. Don't start with the preconceptional counseling, because the ending note has to be for what she has come to you for. Clear, everyone? Dr. Bindu, Archana, Nadra, Abir, everybody.
Sorry to ask you one more question. In the maternal medicine, that once it's a very long session, for example, sickle cell. So we have to mention the routine things also, and then again the special things are related to sickle cell.
Go through a journey. Like, for example, it's sickle cell. Tell the things which are important for sickle cell. What you would say is that it is going to be, in addition to your normal antenatal care, we would do this.
I get you, but in the addition to that normal care, so we have to explain the normal care, or just
see, like for example, anomaly scan is done in every patient. So you would speak that, yes, from the beginning, it is going to be an early scan to detect the baby heartbeat, then down screening and mid-pregnancy scan to see that the baby is developed normally. So these things take only one second, but yes, you have to take through the journey. All right. You have to speak up those and mention the specific points somewhere in between. Go week-wise management. Do week-wise management, right? So somewhere in between, when sickle cell specific things they come, you mention that in between when it comes. For example, growth scan started from 24 weeks. You'll speak at that point. All right?
Right.
Okay. Very good. Well done.
Thank you.
So when we'll practice stations, we'll get clarified more. Okay, so
Dr. Seta, please, one question, please.
Sure, please. More than welcome. Yeah, please.
Dr. Seta, in the preconception counseling, if we start through the whole journey and then we end with preconception, maybe if the time is not enough with us, or like that, we will lose the station.
My dear. This is what you have to practice, that antenatal care, please don't get more than 2 minutes for all this thing. My way was that my antenatal care, intrapartum and postpartum journey gets completed in 1 minute and 15 seconds. You just have to take a round and come back to today when she's in the preconceptional period. So the agenda is preconceptional period, but missing out the antenatal care journey makes you lose marks. So we have to do that again, but doing that in a manner that we touch the entire journey. We take a round through the antenatal care, interpartum and postpartum care, and we get back to the point where she stands today. Okay, Dua?
Okay.
Thank you very much. Thank you.
Thank you.
So you're having duty today, right? At night?
Yes. I have night duty.
I'll just give you the second station after Dr.
No
Sabir.
problem.
Okay,
No
thank
problem.
you very much, my dear. Thank you. So let's begin, guys. Let me see the participants. Everybody has joined. Yeah, so we've got Dr. Sabir, Abir, Archana, Atya, Bindu, Dipti, Dua, Fozia, Girija. Hello, Girija. How are you doing? Hi, Jyoti, Harshipa, Nadra, Shaheen, Sujata. Okay, Nadra, drop in a message. Shaheen, Nadra, Midhat, and Talia is on duty. She would join. I have given her the 4th or the 5th station probably just because she was on duty. Drop in a message in your mini groups, please, everybody to join. Okay. All right. Thank you very much. Thank you, Girija. Okay. So let's begin. So the pattern which we are going to follow today, it's going to be to begin with Dr. Sabiha doing station for Sarvat. And then we will have Dua, Jyoti, Archana. Then it would be Dalia, Harshiba, Abir, and Dr. Atya in the end. All right. So let's begin with station number 1. Dr. Sabia, can you please check your mic?
Yes, I am here.
Okay, thank you very much. And you're audible as well. Thank you very much for volunteering and compensating for the change for Dr. Sarvat. So hopefully we'll have a good station. And thank you very much. Let's see that how it goes. Your 2 minutes, it starts now. Please go ahead.
Okay, next slide.
Yeah.
Can I see the scoring again? Yes. Okay, we can start. Hello, I am Dr. Sabiha, one of the exam candidates.
Sabir, 2 seconds.
Okay.
Yes, please.
Hello, I am Dr. Sabiha, one of the exam candidate. I have read the scenario and I'm ready for the discussion.
Okay, so how had the exam been going, Dr. Sabir, up till now?
Yeah, it's good.
Thank you very much. Thank you. So can you please tell me that how would you manage your patient and what the case exactly is?
Actually, she's a 16 weeks pregnant woman, 28 years old, gravida 2, para 1, and she has a previous history of bipolar disorder in her previous pregnancy. And her family history also positive for mental illness, and she was taking quetiapine and she has stopped herself. This is a case. And regarding her management, I want to start management by knowing more to her. I want to talk to her. I want to know her current symptoms. How is she doing now? How is she feeling? Whether she how is her sleep? How is her appetite? And whether there is any new symptoms for her, and uh, whether there is any suicidal thought she is having, and whether there is any symptoms of depression, and what is the level of her anxiety, and uh, then is there any history of past hospital admission, and whether when she stopped her medication, and what are her concern to stop that medication, and when was she has consulted her doctor for the last time, and after that the um, history of her previous pregnancy, what happened during pregnancy, and whether there was any admission during pregnancy, and how was she during post delivery, and how frequently she was visiting her doctor, and how is the baby, whether she breastfed, and what medication that time she was on, and how was the delivery then, is there any surgery done on her, and any other medical illness she is on, any other medication she is taking, any history of allergy, and what about her family history, as it's mentioned already in the scenario. There is family history of mental illness in her sister, because this all put her on the high risk of relapse in her case. And what is the support she's having at home, whom she is living, what she is doing, whether her partner is supportive, or any family support is with her, and whether she is smoking and taking any recreational drug and alcohol. And then I want to examine her blood pressure, and of course to know how is this pregnancy is unplanned or unplanned, and whether she was taking any contraception or not. After that, I want to examine her to know her blood pressure and her height and weight ratio, and how is the pregnancy so far. Her investigation regarding her blood routine blood test and screening for the Downs, and that's all. And after that, her management will involve multidisciplinary input, like consultant obstetrician and her perinatal mental health physician, and during all the antenatal care, because she's at high risk, so she needs to refer to the mental health physician, and she needs to talk to her regarding her concern with the coitabine. But now, as she already stopped, so perinatal mental health physician, they are the one, they will assess her and they will decide her regarding her assessment with this questionnaire. She is at low risk of the relapse right now, but she is still at a high risk during her late pregnancy and immediately after delivery. So whether she needs now just psychological management or the medication, it needs to be done by the perinatal mental health physician. And at the routine, apart from routine care,
yeah,
red flag sign, whether like if she's having currently severe symptoms like severe anxiety, she's severely depressed, not sleeping well, not eating well, and she has suicidal thoughts, and after delivery if she's estranged from the baby, even during pregnancy if she is estranged from the baby, not taking any interest, then in that situation these are red flag sign, and she needs to be immediately refer to the perinatal mental health physician and might need admission as well.
All right. So what do you understand by the term MBU? What does it stand for and how does it function?
Actually, mother and baby unit is a unit where the pregnant mothers and the after delivery mother and baby both are admitted together whenever they are at risk of severe mental illness or they are having symptoms of severe mental illness. And these units usually they are unit in a psychiatry hospital, slightly away from the main hospital, but they are accommodated there as well, and they have all the facilities or all the specialties managing mental health physicians are there, mental health specialist nurses are there, and they have collaboration with the medical specialties and social workers and community midwife as well, community nurses, community services as well, to support and to keep, actually the aim of these services is to keep the mother and baby together while supporting both, so that they will not be, their bonding will not be disturbed.
Okay, right. So what are the indications of admission in mother-baby unit?
Indications like if somebody is having severe symptoms, severe anxiety, severe depression, and feeling estranged from the baby, and they have hallucinations, like they are having symptoms of postpartum psychosis, and late pregnancy, like history of psychosis last time, and they are now in the late pregnancy. They have history of bipolar disorders, and they are in late pregnancy or after delivery. And currently they are having severe symptoms. So these are the indications for admission in the mother and baby.
Can you please tell me, what do you know about quetiapine?
Quetiapine is an atypical antipsychotic, actually. And her its safety data during pregnancy is not well known. But it's not associated, so far there are no reported any teratogenic effect on the baby during pregnancy are reported. During pregnancy it seems safe because detailed safety data is not so far available, and but breastfeeding it is not advisable.
So do you suggest that this patient should not stop quetiapine on her own, or she took the right decision of stopping it?
Actually, she should not stop her quetiapine in her own. Should be reassured that quetiapine during pregnancy, as there are uncertainties about the safety data of majority of the antipsychotic, but quetiapine she should not stop. She should evaluate it by the perinatal mental health physician. And then they are the one, they will review her status, and they are the one, they will change as a safer alternative.
Yeah, I get that. Okay, so please tell me, what is perinatal mental health network?
Perinatal mental health network is a network of the facilities or the specialities that involve or coordinate together to provide like a very integrated health network support and care for the during pregnancy and after delivery.
What does it include? Yeah,
it includes the consultant obstetrician, definitely, and the perinatal mental health physician, and perinatal mental health nurse, midwives, and GP also involved in this network, and psychiatric doctors also, and community midwives, community health services, and social workers also involved in this network to support the birthing mother and after delivery as well.
So the bell rings, yeah. The bell rings.
Yeah, bell rings already.
So
thank you for your time. Thank you very much.
Thank you. Right, so now you leave and move to the next cubicle, right? Thank you very much, Dr. Sabia. Wonderfully station done. I did this station yesterday with the previous batch. My June batch one-to-one session was yesterday, and they did not know about quetiapine. They did not know about the health network, because this was one atypical station which came in exam. Students who have not read this specifically, of course, we are not very good in the pharmacology, and very well done. Beautifully, you told me about what quetiapine is, what is its actual standing in the management of perinatal mental health, what MBU is, what are the red flag signs. I was happy with your communication. Let me tell you that your strength is because you are in habit of maybe a little teaching. Where like when you talk about the mini group as well, you're always like at the leading end, you know, arranging the things. So structured discussion is your strong point as compared to the simulated patient task. So I just wanted to judge you after the 2 or 3 simulated patient tasks, but I'm happy about your structured discussion. That is your positive point as compared to the simulated patient task. So this is my assessment, which I'm going to work more on your simulated patient task. Things they went well because you're good in your information, in your applied clinical knowledge. Though I have points, I've written down your lines where I have to improve you specifically while speaking. But the overall impression is that your applied clinical knowledge is very good about the topics. This is what I know already, but this is what you have proved today as well. Thank you very much for a good station. To begin with, your introduction, entering into the cubicle was fine. I will tell my points first, then I have solved the station completely for all of you. So I will show the solved station to you guys as well so that you can complete your templates. The points which I've written specifically, which doesn't go only for Dr. Sabiha, please, it goes for everyone. There are certain things by which we can improve ourselves. So it is always a step forward. Never feel that this is something which, you know, we are 100%. Even I, for myself, I always keep learning. So the plateau and the ladder should be rising, and we should, you know, escalate in our performance always. When it goes to introduction, that was all right. I was happy with your introduction. When you started with the first question, how are you going to manage her? There was a little fumbling in, I had to change the slide. So very confidently start with the name and the background. For example, you have to say, I've got a patient. You would say, my patient Freya James, 28 years, who is gravida 2 para 1 at 16 weeks into her pregnancy with a past history of bipolar disorder and a positive family history of postpartum psychosis. So I would like to take my information gathering. Did you understand? There was a little fumbling in starting, so my patient, and then you did start with the name and the age. Like, you know, you're presenting a case. Okay?
Actually, you removed my screen, so I'm thinking what was the gravida.
Okay, so you didn't note it down. That's why I came back to I understand. So for exam, it would be in front of you. Dr. Sabia, in exam, it would be in front of you inside as well. So nothing to worry. All right? This was the first point. I'll tell you, I'll just give you the solved station, but I want a smooth background from the back, mentioning the name, age, gravida, para, and then come to the management. Always remember, whenever there's management, what does it include? History, examination, and investigations. So I would speak in one line. So my management would be regarding the history, examination, and investigation of my patient here. No complete S-bar, Dr. Bindu, because the question is manage her. The question is not summarize your case. I will do the other structured discussion today where you have to do S-bar as well. Okay? But whenever you start the management, please don't start, so my management would be, pick up some background from the station. The background lines are name of your patient, age of your patient, gravida para, what has made her present to you, and then you start the management. So this is the background. This is known as picking up the background and then taking your station forward. All right, Dr. Bindu, am I clear? The difference between the SBAR and here when you have to begin the management, start with the background and then begin. So you will say history, examination, and investigation, and I will take the information gathering. The sentence which you spoke was, everything is all right. This is not something which is going to make you fail, but I want to polish on those lines so that it gives a good impression. You said, I would like to know. Yeah. So what you said was, I would like to know about. What I would say, just to rephrase that, I would like to take my information gathering regarding history of my patient. See, I would speak that domain to tell the examiner that I know that what I have to say, right? I would just speak this word. Second thing is that when you were taking the history, my dear, you were telling the questions as you asked to the patient. So I would like to know about her how was her delivery? This was like one of the sentences you spoke. What I would say in the structured discussion, just to rephrase that, again, I would tell you that the way you said was not wrong. But a better way of speaking in a structured discussion is, I would like to know the patient's history of presenting complaints regarding her sleep pattern, her appetite, her anxiety, depression, her previous illnesses, the medication she had been taking, her last visit to the doctor. So now I would speak the heading. When you said that I would like to know about her previous delivery, how I would start, now would like to take her obstetric history regarding her previous pregnancies, her mode of deliveries. You understand the difference, Dr. Sabia?
I got your point, Dr. Sidra.
Very good, very good. So rather than saying how she was delivered, I would like to know her obstetric history details, because we are talking to an examiner. So the difference between terminologies, just I want to clarify this thing. We practice that in SPT, but a better way in structured discussion is, like, rather than saying, did she have any surgeries in the past? I would say, I would like to know about her past surgical history.
Sorry to interrupt you, Dr. Sidra, but in case when we will be there will be 14 stations and we have to keep on fluctuating from structured discussion, then wouldn't it be more difficult for someone, even we do the practice for 6 more months?
Know. See, I will tell you, whenever the examiner is in front of you, Dr. Tia, remember, whenever the examiner is in front of you, never worry about this thing that the patient is here and you will start asking. Remember, in structured discussion, speak your headings of the template, like the surgical history. As Dr. Sabia said that I would like to know whether she smokes or not. I would speak how that I would like to know about her personal habits, like smoking, alcohol, any recreational drugs. So the questions are the same, but don't speak whether she smokes or not. How was her delivery? I mean, don't ask the question, name the question. There's a difference between asking a question and naming the question. So I would say the same. The words she said was perfect, but this is just to groom you guys that in structured discussion, name the template should be in front of you, like in your mind, and you name the headings. So the surgical history regarding her support, rather than saying, see, there are 2 ways. I'm telling you the right way in structured discussion. First way is, how was her support? And the second way is, I would like to know about her support. So, so there's a difference in just speaking and formulating your sentences in a structured discussion. All the terminologies used for Dr. Sabia were perfect in a go, but I would like to rephrase just a difference between, like, patient is not in front of you and an indirect speech you have to use. So in simulated patient task, you ask the question. And in structured discussion, you use an indirect speech. That is, you formulate the question that I would like to ask. I would like to know about her surgical history, her family history, her personal habits. So this is actually the way. Dr. Sabia, did you get the point, my dear? How to go? Just the idea is the same, but just to rephrase. Okay.
I got your point, Dr. Sidra. I got your point.
Thank you
and
so
it's
much.
Very nice and perfect way to impress the examiner.
Thank you so
much. What you are conveying, we are getting it. Don't worry.
Thank you so much. I'm really grateful. Now, again, when you completed your examination, you came to, I would like to know about whether it's a planned or an unplanned pregnancy. So that would be an HOPI, okay? As we do in the history. So after examination, you came back to the planned or the unplanned pregnancy. The sequence should be at the top, like about the history of presenting complaints, the details of the pregnancy, conception, was it a natural conception or was it a planned or the unplanned pregnancy? So this question would be at the top. It came after examination. Then you examined the patient and you did the investigation. I will just tell you a few points were missing there. I'll just tell you in a bit. And you were good in this element that you said that she's low risk at the present. Why? Because if you go to the chart, which I gave here, so that has shown that she has a total score of 2 in GAD-7, and that is score of 0 in her PHQ form. Red flag signs, I will just show you about that question, and quetiapine and question number 4 perfectly delivered. I was very happy about your question number 3 and question number 4. They were absolutely on mark, nothing I have to add there. When you asked me to change the slide about the scoring, I had a little concern. May I know that when I changed the slide back to this, and you asked me, Dr. Sidra, can I see this slide? What was in your mind? What did you want to see here?
To me, Dr. Sidra?
Yeah, Dr. Sabia. What did you want to see when you asked me to change the slide? Yeah.
Actually, first I thought I was concentrating on the first one, like score 0. I didn't see the second one, the GAT-7. So for that, I want to see what is
perfect. That's
the score for GAT-7.
Very good. Okay. Now let me tell you that what happened in exam. I have to give you that full impression what students they had difficulty in exam. They said, ma'am, it was such a difficult station. It was a complete station candidate instruction, and then there were 2-3 sheets with lots and lots of questions, ma'am, and we couldn't complete. We just read the first and the second, and we were lost. We could not see the last questions. Why? Because never in life patient health questionnaire PHQ-9 is seen earlier. Neither the generalized anxiety disorder screener GAT-7 is seen earlier. And that was the reason they said that, ma'am, we couldn't complete that. What was those pages about? Because there were 8 to 9 questions on one form and 8 questions on the other form. Here you people go wrong, and I'll teach you that what do you have to see. Don't fumble outside the cubicle. You just have to see the scoring. It is a complete pre-decided form. It is not something that this question number 1 would be changed or question number 6 would be changed and you need to read everything. Even you don't need to see this if it's all 0. The first thing you all need to see is the bottom of the page, remember, in exam, and that is the total score. That's it. And remember, below that, there's a table given in which the interpretation of the score is also given if you don't know. Like for 0, there's no ambiguity, but you should know that 0 or 2, what does it mean? Right? So just see the total score, and inside the table you can see, is it mild, is it moderate and severe? I will just tell you in a bit. I wanted to clarify this chart so that if it comes as a repeat station, you people don't have difficulty in solving the station. You just don't have to read all the questions. You just have to see the total score and interpretation. I'll tell you in a bit. Let's begin with the station. For question number 1, and it's going to be for question number 1, information gathering. I need to know more about her history, examination, and investigation, because these 3 parts are the management. I will like to manage her dividing into her antenatal, interpartum, and postnatal care. This is what our template is. So it's going to be a multidisciplinary team, the drug modification, regular checks, good advice to lower the risk, and when to seek help. It is going to be in hospital delivery during her interpartum care, close monitoring, would maintain her good hydration and adequate analgesia. In the postnatal care, close monitoring for postpartum depression and the psychosis, she would require good support and baby check. We would discuss about when would we discharge her, and the contraception advice would be given to my patient. So this would be the outline, taking the history template, examining her, investigations, and doing this complete compartment-wise antenatal, interpartum, and postnatal care. Red flag signs are given in the TOG article, friends. It's a table in the TOG article, postpartum psychosis, perinatal mental health. This red flag signs was one question. If you've not revised that in exam, it becomes a problem. Remember, there are only 3 red flag signs. First is if she feels recent significant change in the mental state, or there are some emergence of new symptoms, new thoughts or acts of violent self-harm, new and persistent expressions of incompetency as a mother, or estrangement from the infant. So these 3 were mentioned by Dr. Sabia, but she added one more. That was severe anxiety. Right, Dr. Sabia? Right? So these 3 are the red flag signs. Okay? These 3 are the red flag signs. Okay? We have to remember. So you did mention all these 3. So we should know that according to the TOG article, these 3 are the red flag signs. Your description about MBU was perfect. It's a mother-baby unit. That's a specialist perinatal inpatient services. The mother-baby unit is a specialist perinatal inpatient services, and it is to provide treatment of all serious mental illnesses while maintaining the mother-infant relationship. The idea is to keep them together. So what are the indications? The red flag signs, all 3 are the indications. That is rapidly changing mental state, any suicidal ideation, particularly of a violent nature, pervasive guilt or hopelessness in the patient, significant estrangement from the infant, any new or persistent beliefs of inadequacy as a mother, and the evidence of psychosis as well. All these are the indications of admission in MBU. As per these indications are given in the postnatal mental health NICE guideline. Quetiapine perfect spot-on answer by Dr. Sabia. It is an atypical antipsychotic used to treat severe mental illnesses and can act as dopamine, serotonin, and adrenergic antagonist. It's a potent antihistamine with some anticholinergic properties as well. I'm sure when you get this question for the first time, you don't know the pharmacology of quetiapine. So we have to memorize it because it has come twice in exam. It might come as a repeat station. We should be knowing about the pharmacology of quetiapine. It can interact with many drugs and antibiotics and can cause serious side effects as well. Also, it has serious interactions with alcohol. We don't have enough safety data for the use in pregnancy. It is not recommended during breastfeeding. However, any perinatal mental health treatment medication, it is suggested that patients, they don't stop the medications on their own. It is always the decision of their concerned specialist, either to change the dose, to change the drug, or to change or stop the medication. Therefore, she should get connected to the perinatal mental health team immediately, and they decide whether they have to continue quetiapine or they have to start with some alternative for this patient, keeping her strong history in mind. Last question was Perfect Perinatal Mental Health Network. Yeah, it's a clinical network that should establish the perinatal mental health services. I've taken this copy-paste from the NICE guideline, friends. It is managed by a coordinating board of healthcare professionals, commissioners, managers, and the service users with the carers. What it includes is, it includes the specialist multidisciplinary perinatal service in each locality, and along with that, access to the specialist expert advice should be there regarding the medications in pregnancy and breastfeeding. Also, a clear referral and the management protocols for services across all levels of existing stepped care frameworks, and the pathway of care for service users with defined roles of each individual according to their competencies of all professional groups are involved. Now, this perinatal inpatient, it should have the facility designed specifically for mothers and the baby. Generally, it contains 6 to 12 beds each. It is staffed by specialist perinatal mental health staff. Appropriate care for the babies is provided. A liaison with general medical and mental health services is done. It has availability of full range of therapeutic services and closely integrated with community-based mental health services to ensure continuity of care and minimal length of stay. This is CG 192, the NICE guideline, antenatal and postnatal mental health. This question in exam of the network was taken from this NICE guideline part. That is the reason I've taken a screenshot so that you people don't forget from where did they ask this question. I know for the first time it is a difficult station, but if you just stay composed and speak something out of this structured discussion, you manage to get at least borderline. Nevertheless, question number 2, 3, 4, 5, 6 were perfect, Dr. Sabia. Only in question number 1, a little improvement I would like to you to have just for rephrasing. That's it. And that too, to polish you. So it was a clear-cut pass station, Dr. Sabia. I'm glad that we are starting with the rock on performance. Very good. Well done. Now, I would like to tell you that what is this patient health questionnaire form all about and how we have to deal in exam. See, don't get scared by a long sheet of PHQ or GAD-7. This is a fixed form which is always there. Can you see the shaded part here? Zeros and ones are not shaded, but this part always in PHQ is shaded. So I wanted to give some better understanding so that if the forms are there, you know that what do you have to see. The first thing in the form, please match the name with the patient. That's it. So it belongs to the same patient. This is the first thing you have to see in exam. Second thing, you have to come to this part and see what is the score. Similarly, in GAD-7, see the score at the bottom. That's it. Your job is done. Whenever you come to the patient health questionnaire, there are fixed 9 questions. Little interest, feeling down, trouble falling or staying asleep, little energy, poor appetite. All these questions we generally ask in the perinatal mental health, but when it comes to a form, don't start reading number 1, number 2, number 3.
It is not required, please. Students, they do this mistake. They start reading, okay, 1, okay, 0, 2, okay, 0, 3, okay, 0. No, it doesn't make any difference. They have filled the form for you. So please see the scoring. What is the interpretation? Am I clear, everyone? Where do the students, they make mistake? And when they go inside by having this feel that we have not read the form outside, what would we do? Here they go wrong. Am I clear, everyone? Please be active in the chat box so that I can understand that you people are getting the same, just what I'm trying to transfer. Clear? Okay. So please see the last part where the scoring is done. Similarly, if you see the generalized anxiety disorder screener, 7 questions are there. Again, the first 2 questions are in GAD-2. Remember, the first 2 questions are in GAD-2, feeling nervous, anxious, or on edge. Not being able to stop or control worrying. This is the GAD-2. When we add 5 questions, it becomes a GAD-7. So every time, yes, Dr. Athiya, every time score would be there. If at all, Dr. Athiya, in the end score is not given, what do you have to do? You have to add, for example, 1 and all zeros are there and then 1. You will say it's 2. They will at least mark, because sole form giving without marking is not of any importance. So if they've not done the total, in the worst scenario, they would definitely do the total, because this is how we fill the form of perinatal, the patient health questionnaire for asking about the perinatal mental health. If it's not done, you can simply add it up here. So the total score is this. What happens next? You should be knowing that for initial diagnosis, you need to know that this is given at the bottom of the page. So you should be knowing that 1 to 4 is minimal depression. You should be knowing that 5 to 9 is mild depression, 10 to 14 is moderate, 15 to 19 is moderately severe, and 20 to 20.
This we have to learn.
No, this is given at the bottom of the chart. So you see the score and you just see that where does it fall. This is the second part of the chart. Just at the bottom it is given. You don't have to learn this. Am I clear? So just in exam, yes, make use of your 15 seconds. Why am I emphasizing on this point again and again? That students, they entered into the cubicle with extreme nervousness because they could not complete the reading, because their reading was in the wrong direction. They were reading each question. You just have to see at the bottom if the score is given, and then you just have to see where does it fall. Am I clear, everyone? In exam, it was 0. So that's the easiest thing, that she is low risk at the moment. But even if it's more score given, for example, if they give you 5, you should know that she falls into the mild depression. You'll say that in your assessment part in your first question. So according to the questionnaire provided to me, she falls into the mild depression, and she would be referred, because of her history and her current state, to the perinatal mental health. That's it. Am I clear, everyone, that how you're going to do? Just for your knowledge, why do they shade few parts? Why do they shade few parts? Because these shading puts the patient on high risk. They have shaded this block just to tell you that patient depression questionnaire says that if the patient has at least 4 ticks in the shaded section, you consider that yes, they have a depression disorder. Going back again, if any 4 ticks are there, here, 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 any 4 ticks are there in the shaded box, the interpretation is that it contains, yes, a depressive disorder should be sorted out. Now they say that if 5 shaded parts are there, it would be in the major depressive disorder. That's it. This is my requirement, that all my students should know at least this much about the patient depression questionnaire. If 4 are marked there, you would say that yes, we are going to consider depressive disorder. And if 5 are there, it would be major depressive disorder. This is separate to that of the scoring part. That's why the shaded interpretation is taken separately. Am I clear, everyone? So my requirement from all my students is, if you can take the printout of patient health questionnaire, not because that you should learn it, just because that anything which comes in exam for the first time, you get fumbled there. So you have a look on this so you don't find it something like alien in the exam. Then you just know in exam, please confirm the name, that is first part, see the total score, and after seeing the total score, just see here, where does she stand? That's it. If scoring is done and 4 are here, you will consider depressive disorder. And if 5 are in the shaded section marking, 5 are there, you will consider as a major depressive disorder. Again, would like to tell you that be confident. It doesn't make any difference. Even it's 4, even if it's 5, even if it's nil, like in this case of Freya. It was nil, but she had a positive family history. The management remains the same, and that is with the perinatal mental health referral. Am I clear? So why to worry? Why to worry? If it's a major disorder, it's perinatal mental health who is going to manage them. If it's minor disorder, that is only 4, they will manage that. And even if it's nil at the moment with a positive family history, they will manage. So why are you scared in exam? Yeah? Right?
Yes, Dr. Sidra.
Yeah.
Actually, if it is nil right now,
Exactly.
because she is at high risk of mental health illness,
Yeah.
so it can be on the higher side in the late pregnancy or after
Very
delivery.
good. That's the reason. So my idea to give you guys is that don't get fumbled. The interpretation, yes, you should know. So don't get fumbled, but the management remains the same. You are not doing anything. You're going to refer to the perinatal mental health team, and they are going to decide for this patient. Am I clear, everyone? Harshiba, SPT up till now didn't come. As I'm doing the exam stations, it came as a structured discussion. If you want, I will do that. Maybe one station, if you want, I can do that with you guys, just because to give you tough time as a depression patient. It is in Oxford as well, right? Thank you very much, Bindu. I made these charts just for this reason that, see, the students who see it for the first time in exam, they get disturbed in exam that we didn't know from where to start and where to read and where to end. And they take their 2 minutes, and inside the things even which they know, they forget for this reason, because in the back of mind, it's just there that we did not read what was outside. So you should be knowing that everything, what you have to see, I'll do a recap. My students should see the name just to confirm that it's PHQ of the same patient who is in the candidate instruction. That's it. See the total score or see the shaded part. So here, in just a blink of eye, I can see that none in the shaded part is there. So I'm happy about her condition at the moment. Simple, right? Remember, for the GAT7, if it's 0 to 2, it is going to be none, right? For GAT2, 3 to 6 is probable anxiety. For GAT7, 0 to 7 is none, and 8 plus is probable anxiety. Again, you don't have to memorize this. This is given at the bottom of your GAT2 or GAT7 score chart. So the problem in exam is that students, they don't know that where they have to see and locate the things. So just see here, it's 2, and then you see the table at the bottom. So she has none risk at the moment. Am I clear, everyone? I know I took time, but I want that if this station comes, you people don't have difficulty in interpretation of the chart. Right? Clear? Okay, very well done, very well done. Thank you very much, Dr. Sabia, for a wonderful station. It was a past station. Next time, be ready for SPT. In fact, next all stations would be SPT for you, because I'm happy, I'm comfortable with your structured discussion now. So no more structured discussions. Okay? All right. Thank you very much for a wonderful start. I hope you people are clear about how to manage the structured discussion. Up till now, the SPT didn't come about depression. There was one about not being able to sleep and taking sleeping pills, but that too, that had some other concern in November. We'll definitely do all these stations in the postpartum care when it would come there, right? Okay, yes, SPT. With a smile, Dr. Sabia. With a smile, we will do SPT. No nervousness at all. All right. So we've got Dua here. She has to go for the duty today. So we'll manage to do her station. Hello, Dua. How are you doing?
Hello, Dr. Sid. I'm fine.
Okay, so we'll do a station, Dua. Your voice is audible. So let's begin with the, thank you very much, Dr. Sabia, for a smile. So that keeps me going. So 2 minutes, Dua. Let's start now.
Okay, Dr. Sid. Okay.
Start, please.
Hello. Hello, Dr. Sida.
Yeah, start, please.
Hello, I am Dr. Dai, one of the doctors in the preconception clinic today. Can I confirm your name and age, please?
Hi, doctor. Doctor, I'm Chantal Wilson. I'm 22 years.
How would you like me to call you?
Chantal is all right.
Okay, Chantal. Chantal, as I know that you are here today because you are planning to have a baby and you have a condition known as sickle cell disease. Am I correct?
Yeah, exactly, doctor.
Okay, Chantal, just in a moment, we will try to discuss all your condition and then we will try to find a safe management plan for your condition. But just before that, I want to ask you some questions to know more about you. Is it okay for you?
That's all right, yeah.
Okay. Chantal, can you tell me more about your problem?
At the moment, I don't have any problem. I'm fine, doctor. I just wanted to have a baby now. We were planning that it's high time that I should get pregnant.
Okay, that's good. That's nice to hear about that. But when this condition started with you and what happened during the last time for the sickle cell?
Yeah, I was diagnosed maybe 10 years back about this condition. I'm in contact with my doctor, though my last checkup was 1 year back, but I had my severe painful crisis 3 months back, and I got admitted for like 7 days. I got better after painkillers and was discharged. On and off, maybe 3 to 4 months, I do have blood transfusion because my hemoglobin does fall, doctor. And also, I have recurrent waterworks infection. I keep on taking the antibiotics for that as well.
Okay, and what about the infection right now? It's okay? You are still on antibiotic?
I'm not taking antibiotic at the moment.
Okay, that's good to hear about that. Apart from this condition, you are generally fit and well?
Yeah, otherwise I'm okay. Yeah.
Okay. And as I see from your case note that you are taking a contraception in the form of injection. Am I correct?
I had it 3 months back. I'm just due for it now, doctor.
Okay, we will discuss that in a moment. Sorry to ask you some question about your social life. How is your partner? He is generally fit and well?
Yeah, partner is okay.
Okay. He did any testing for this condition, for the sickle cell, or any other problems in the blood problem?
No.
Okay. Sorry to ask you again, any history of sex sharing disease before?
No.
And what about your period?
My periods are regular, doctor. Every 30 days I get for 7 days.
Okay, that's good. And have you ever been pregnant before?
No. This is first time we are planning now.
Okay. And also as regard your medication, as I see you are taking medication now, you as known as hydroxycarbamide. Any other medicine apart from that?
That's it. I'm taking hydroxycarbamide. I am better on that.
Okay, that's good. And any allergy for any medication?
Yeah, I'm allergic to penicillin, doctor.
Can you tell me what happened?
Yeah, I have a rash. I have severe discomfort on this.
Okay, I will document that in this note. And which antibiotic you are taking right now if you have recurrent infection?
I don't take antibiotic. I'm not taking at the moment, but whenever it comes to the antibiotic, they give you erythromycin rather than penicillin, doctor.
Okay, I will document all of that in your notes. And any idea about your blood group?
Yeah, that's O positive.
Okay. Any surgery in your tummy or down below?
No, never.
Any family history of concern you want to share with me of same condition?
I am not aware of.
Okay. And some question about your social life choices. Do you smoke?
No, I do not.
Drinking alcohol?
I don't, doctor.
And don't ask me any recreational drugs?
No, doctor.
Okay. Just I want to know, in general, we are asking most of our patients about that. Do you feel low or depressed in the last 4 weeks?
No, I'm otherwise fine. When I get severely ill, yes, I get a little depressed, but otherwise I'm a happy person, doctor.
I'm really happy to that. And any idea about the relationship between your weight and height?
Yeah, that's all right. That's 23.
Okay, that's good. Thank you for sharing this information with me. Anything else you want to add?
No, that's it. Would just like to tell you that my vaccinations are due as well, and my eye checkup that was also done maybe 6 months back.
Okay, because you told me at the beginning the last checkup 1 year, but you did the eye examination
Yes,
in
yes,
the
that
last
was
6
6
months.
months back. Yeah.
Okay, okay, that's good. Again, I will go back to your notes, and also I will contact your treating team to know more about your condition.
Thank you very much.
And also, before going, so to discuss what is we are going to do to make you in a proper shape before before to have a baby, we will review what blood test remaining for you, because we have to, as you said, we have to give you the vaccination before going to your pregnancy. We will check for the rubella, we will check for hepatitis, and also any infection to give you the proper vaccination for that. And also we have to be sure that you have a healthy diet and having a healthy lifestyle, because this is initial to have a healthy pregnancy. Am I clear so far?
Yeah, you are. Thank you.
Okay, and just I want to tell you, most of the women who have a sickle cell disease, if they are in good control, they will have a healthy pregnancy and healthy baby. But actually, there will be some risks from the sickle cell on the pregnancy and also on the mother and on the baby. These risks in the form that maybe if the woman is not have a good advice about the good hydration and about the good lifestyle, maybe they will go into a painful crisis like you have before. They will need admission to the hospital. Maybe there will be a condition like repeated infection like you had before, increase in the blood pressure or protein in urine. All of these risks, maybe we will tell you how to decrease during the pregnancy. And also as regard the baby, maybe due to the effect of the condition, maybe the baby will be grow smaller, you will need to be delivered earlier than the expected due time. But as I told you, we will go to decrease all of this risk. So your journey during the pregnancy, how we are going to do so that I will take you quickly through the journey of the pregnancy. And at the beginning, a group of doctors will take care of you, including our consultant, and the blood doctor, of course, will take care of you also, a specialized nurse and a specialized midwife. And also at the end, the baby doctor and the anesthesia doctor will be involved. You will have a frequent scan. We have to give you folic acid, 5 milligram actually. We will start from now, and it's better to continue it till 12 weeks of the, maybe you will continue throughout the pregnancy, because in your condition, it's better to continue for that. And also because of the high blood pressure, maybe we'll give you aspirin to protect you from the high blood pressure. And also we will need to do frequent checkup of your blood pressure and protein in urine during the pregnancy. And of course, apart from the routine follow-up that any woman have during the pregnancy, maybe we need frequent visit and frequent scan, apart from the normal head and toe scan and the down screening and the dating scan. Am I clear so far?
Yeah, I get that. Okay. Yeah.
Okay, and during the delivery itself, and maybe by 36 weeks, if everything is going fine, we will make a plan for your delivery. Maybe we will need to deliver you earlier at 38 weeks. We will start your labor. You can go for vaginal delivery unless you will have any problem that need to go for cesarean section other than your condition. Am I clear?
Yeah. Yeah.
Okay, and after delivery, it's normal, you can breastfeed. And also for them, we will give you proper contraception to protect you from unplanned pregnancy. Okay?
Okay. Yeah.
And the most important thing that maybe during your condition, you will have a risk to have clots in your blood. So we will assess the risk to have blood clot so over the pregnancy and also after delivery. And at any time, if you need any blood thinning agent, we will give to you. Am I clear?
Yeah, I understand that, doctor. Thank you. Yeah.
Okay, and coming to today, as I told you, you are taking the medication. It's called hydroxycarbamide. Actually, this medicine is not good to have it during the pregnancy, and you have to stop it at least 3 months before. So what we are going to do now, we will refer you to your doctor to check your condition, and also we will stop this medication if it's feasible for you. And as regard the injections that you are having, it's better not to take it because you want to have a baby, and this may delay your you delay due to have a pregnancy later on once you stop it. So it's better to have another method of contraception. Okay, we will discuss that, which is method will be most suitable for you. And also because you have a lot of blood transfusion, maybe we will need to do some tests to check if you have any proteins, which called an antibody in your blood, because this is may affect in your pregnancy, may affect your baby, and also it may be affect your requirement of blood during the pregnancy. Am I clear so far?
Yeah, I understand that, doctor. All right.
Okay, so what we are going now, I will give you this folic acid 5 milligram. We will check if you have another method of contraception. It's better also to check your partner to check if he has any problem. okay, before going to that, because this will affect the health of your baby, and if the baby have any chances to have this condition later on. And I will write back to your GB. I will give you patient information leaflet, and I will arrange another appointment for you with my consultant. Anything else you want to ask about?
Thank you, doctor. Thank you very much.
Thank you.
Very well done, Dua. Very well done. A splendid performance. Believe me, in every part of your station, you went perfect, Dua. What happened today, Dua? How did this go? Starting from the introduction agenda, every part of information gathering was so smooth. Antenatal care, and before that, coming to the effects and taking through the journey, a beautifully done station, and taking out each and every patient's safety beautifully. Does
Thank
it?
you, Dr. Seda.
Beautifully done. I mean, I was so happy that I always, when I take the feedback notes on my notebook, on the left-hand side is always the positive points, the star points. On the right-hand side, I always write down those points where I have to rephrase. Believe me, I had almost blank right side till 7 minutes of the station. And that was perfect. That was perfect. The way you were speaking, the way you were talking and communicating, the way you were checking my understanding in every compartment. This is what I always teach you guys. Did you people notice the change? Dua was fine in the previous station as well. But today she was perfect at every part. Wasn't she? Yeah? Beautiful. And the best part was the time management. The pre-conceptional station goes such a difficult station, but she managed the time. Yesterday, a student took 13 minutes on doing the same station. Very well done. Very smooth.
Thank you.
Well,
Thank you.
perfect.
Thank you.
Just keep on going in this manner, believe me. And I write it today that you are a pass candidate. You're definitely a pass candidate. The way you spoke and the things which you spoke, like about the condition, the things which you spoke about antenatal care, going through the journey, all those lines which I teach you somewhere in between, that shows what? That shows that you had been practicing. Because without practice, the things, they don't get absorbed. So you are practicing and the things that are coming out just one after the other. One after the other. There was no fumbling at all. The more I speak in appreciation, the less words I have. Wonderfully done. Spectacular performance, Dua. Very well done. Very well done.
I want to thank Nadra for all of that, because really she is suffering with us a lot.
Ah! Nadra, it goes for the group B. Wonderfully done, my dear. Who did this station in the mini group? Dua?
Actually, we are discussing the case. Yeah. Actually, me and Nada, who are the one who did most of the cases the last week. So we are discussing the case, we make the points, and then we will discuss what we will do more than doing the station at a whole.
Very good. Well done. Nadra, lots of thanks to you as well. This shows that how you people had been practicing and the things are just in front of us. The way she went, and the beautiful part was when she came to DMPA, and I'll just come back to it in a bit. So that was wonderful. That means that she knows that what are those points. And again, I would compare with my other students. See, I'm doing these stations, maybe total, I have 100 students at the moment with one-to-one practicing. So I can compare you guys. This station, when done with other girls, with other groups, they did not mention this point and they continued the injection. See, it has a fertility delay. It has to be changed. Though it's the best contraception, decreases the sickle cell crisis. Best part was that it went smooth. She knew that what she has to speak. She knew where I have to stop and I don't have to go into detail. Very well done. Perfectly done. Introduction, I gave you a star. Agenda making, I gave you a star on your agenda. Spot on 2x2 in information gathering. Beautifully taken information gathering about the details of sickle cell disease, about the discussion coming back to DMPA. The line when you spoke, I gave you 2 stars on that. Checking about the partner testing because it's an autosomal recessive, and then mentioning in the end, it has to be done in the preconceptional care. That was perfect. You checked about the gynecological history, about the penicillin. You did note down this. That was very good. Blood group patient safety was done. About the surgery, family history, beautifully asked about the smoking, alcohol, pardon me to ask about recreation drugs. This is all what I teach. And if you have absorbed that, I'm the happiest person on this planet. Well done. BMI, in the end, about the support, you were very happy. Your response was perfect. I was very comfortable talking to you as a patient. You told about the rubella hepatitis B, the blood test before coming to, then you told about the effects on the mother and the baby. In baby, I just noted down, this was the first point where I had to write down one thing, and that was In the baby effects, you did tell about the FGR or the early preterm birth, but you had to mention, and the biggest effect which can be that baby can get the same condition as that of the mother. Okay, so this is one effect which you cannot miss, because this is in the preconceptional counseling, the most important thing. So I was waiting for this effect, that baby can have the same condition from that of the mother. Baby can get the condition. So this effect in the baby was missing, but you managed to touch this point in the end in the preconception counseling, so that was good. Best thing which she did, being organized. This is what I tell you guys. You are always knowing the things, but lack of being organized gives a false impression or not that impressive look to the examiner. She started her antenatal care with a group of doctors' care. When students, they do that, they start the antenatal care with the folic acid and with the ultrasound, and somewhere in between they say that the group of doctors will take care. So why not to start your antenatal care in MDT? So beautiful rehearsal done before dua, and that was very evident by your communication speed and the pauses which you were taking. Did you people notice that after every part she checked my understanding? It was not that she was speaking antenatal care. Dr. Sabia, did you notice that? Atia? She did not go to the intrapartum until she checked my understanding for antenatal care. She did not move to the postpartum care until she checked my understanding for the intrapartum care. This is known as checks and chunks. Checks and chunks. And on examiner sheet, we have got one block for this. Checks and chunks, checks and chunks. So she gives information in chunks and she checks my understanding. She gives information in chunks and she checks my understanding. That is what I tell you. When I make the blocks in the algorithm, I make it for this reason, that you people know that one compartment is done, moving to the next part. The next is done, moving to the next to it. So this is how you go smoothly. I was happy with Dr. Sabia in the first station, and you've made even happier after doing the second station. Very well done. The last preconception care, it was perfect that you told about the folic acid starting today and about the DMPA shifting to the mini pill. That's fine for her, and referring to the sickle cell specialist. Communication with the patient, undoubtedly a beautiful communication, Dua. And the day when you joined me, I would say that you were never failing in the very beginning, because I know that you had been preparing early as well. So maybe I would grade you out of 10, maybe somewhere 4 or 5 when you join me. And today I grade you 8 by 10. And we have to reach to 10 by 10 just in next few months. Very well done, Dua. In history of presenting illness, about the sickle cell disease questions, she was asking about all the details as an open question. That was fine. About the current control, about the test, about the quality of life, how had it been, picking up the information from the candidate instruction and asking the history, obstetric, gynae, family, surgical, drugs, personal, everything was done beautifully. Did you people notice that before mental history, she just spoke a line? So this is we generally ask about to every patient of ours. So this is how you make your patient comfortable. So it's not that I'm asking you only. So don't feel something bad about that, right? So these are beautiful lines which makes your patient comfortable. But at the same time, her speed wasn't faster for me to understand. She was not rushing through the station, but at the same time, she was not slower, because at the back of her mind, it was that it's a preconception station. I have to cover a lot. This comes with practice. This comes with practice. Beautifully done patient safety. Everything was covered in the patient safety. Revising medication was the best point, and she said that 3 months, that was very good. Again, students, they're not sure of that. Yesterday, one of the students, she stopped for 6 weeks. So applied clinical knowledge went wrong. For sickle cell disease, I would like to tell Chantel that yes, it can have worsening of a condition in terms of painful crisis. Anemia can be there, leading to blood transfusion risk. The chances of having clot formation in the pregnancy and having risks of infection. Having proteins in the urine is one of the risk factor in this condition, and the baby can be smaller in growth. You can go into labor earlier than the due date, and the increased chances of cesarean section are also there. In terms of baby can be smaller in growth, can be smaller and lesser in weight at birth, and can have complications of early delivery than the due date, and baby can get the same condition as that of mothers in this condition of sickle cell disease. It is going to be a team of doctors, and regarding the blood, talk to a specialized nurse and the midwife and a consultant taking care of you. If in exam question, they say that the partner is also a carrier, I didn't say that. But in exam, she can say that my partner is tested and he's a carrier. I'll come to the inheritance pattern just to check you guys in a bit. You can offer her that before getting pregnant, you can get tested. We call it as pre-implantation genetic diagnosis, or a blood test from the mom can be done, or the needle test can be done to diagnose as well. This would only be if the partner testing is done and he's a carrier or he's diseased. Okay? Only in this case, this bullet number 2 would be spoken. In the case which I just spoke, that partner is not tested yet, of course, you can just skip it up. About the folic acid 5 milligram, about the vaccinations and antibiotic requirement during the pregnancy, the blood thinners, and the pain relief medications if the pain crisis occurs. We will aim for the vaginal birth around 38 weeks, and we'll continuously monitor the baby during pregnancy. We'll keep you warm and well hydrated to avoid the complications, Chantal. We will give you pain relief during the labor, avoiding pethidine. This is your patient safety. It's better that you speak. Dua, just add in into your template about avoiding pethidine, because that might be in the block of patient safety with the examiner. Okay, and we'll give you some specialized medication to avoid bleeding, to prevent bleeding after the birth of the baby. Why? Because sickle cell anemia itself is an anemic patient, so active management of 3rd stage of labor is done. After the birth of the baby, we'll encourage you to the breastfeeding and avoid the combined pills. We'll give you suitable contraception advice, and we'll assess you for the blood thinners. We'll offer support, and the baby would be tested by the baby doctor by simple pricking at the heel and testing the baby. Coming to the preconceptional care, would suggest that you start folic acid high dose 5 milligram today. The medication you're taking will connect to the sickle cell specialist, the blood doctor, who would give you alternate to that, because this medication at least has to be stopped 3 months prior to the pregnancy. If she's a smoker in the question, avoid smoking, rubella vaccination, hepatitis B, and the flu and other vaccinations has to be done. If partner screening has been done, well and good. If not done, please offer partner screening as Dua did here. Your eye screening, your blood pressure, your heart checkup, and your urine checkup would be done prior to the getting pregnant, so that we know that if we have to deal with some situation and treat you prior, that you embark on pregnancy. And this is the patient information leaflet and connecting you to the support group, so that you can talk to women who are having this condition and you can decide for yourself. For today, refer her to the sickle cell specialist, to the blood doctor, so that we can plan the things forward. Till then, you can shift her to the mini pills, so that her time period of delayed getting pregnant of DMPA as a side effect gets reduced. Very well done. Bindu has a question. Do we ask to test partner then in the management plan, in the preconceptional care? You will offer partner testing here. Now, let me just ask a question. That in preconceptional counseling, there can be a station change to this, in which I say as a patient that, yes, doctor, I am a patient Chantal Wilson. I have sickle cell disease, and I tell you that my partner has been tested and he's a carrier. I want one volunteer who would explain to me what can be the risk to the baby, please. Who wants to explain to me, Nadra?
Mummy.
Okay, yes, please. Yeah, my dear.
Half like the mother and half like a father. That means milder form. Half babies can be of milder form and half will be of severe form.
Very good, Archana. Well done. So this is the easiest way. Very good. Well done. When I asked this question to one of my UK students who is appearing in this exam, the confirmation has been done for him. And he yesterday started explaining me the entire pedigree. And he was like, see, because your partner has one faulty gene, so when it would go, half of would be carriers and half of the babies would be diseased. They can have anemia. The simplest terminology which Archana has used is the perfect terminology. And that is, half of the babies, or chances are that half of the babies are like that of mom and half of the babies are like that of dad. That's it. So the best understanding she can have, okay, my partner is a carrier and I'm diseased. 50% chance. Clear? This is the easiest terminology which doesn't waste your time. Now, if I ask a question that the patient herself says that I'm diseased and my partner is normal, what would be the answer? Nadra? Girija, would we have some normal baby? What would be the pedigree? Dr. Sabia, Atya, Sarvat?
Half will be normal, and 1 in 4 will be carrier.
Dr. Sabia, patient is diseased and partner
Yes.
is normal.
So 1 in 4 will be
Half normal, half
carrier.
Draw the pedigree, Dr. Sabia. Yes, Abir. Abir wants to answer. Yes, Abir.
Yes, doctor. Doctor, all the children are carrier.
Very well done. All the children are carrier. Let me do that for you.
Yeah. She's
Dr.
right.
Sabia, she is
I
diseased.
forget. Yeah.
No, I will draw it for you guys, please. This is diseased.
Okay.
Small s.
Okay.
And this is the normal patient. Okay, this is the normal husband. And this is the patient. So all the patients are going to have one small s. That is the effective. So whenever the effective genes goes, all the sons or the daughters, whatever are the kids' offspring, they are going to be carrier. Am I clear? Everybody would be carrier. You simply draw it in this. Everybody would be very good, Jyoti. Well done. Everybody would be carrier. So no normal here. Right? No normal here.
Yeah, all will be carrier. Yes.
Very good. Now she is diseased herself and she says, yes, my partner is also diseased. So what my suggestion is, Atya, ensure that in group A, also in group B, Nadra, please ensure. In group C, I would like that Jyoti, you ensure as well. And for group D, please, Divya, ensure that you people draw 4 possible pedigrees and stick on your template. Why? Because in exam, you don't have time to draw the pedigrees. Immediately, patient comes with an answer, yes, my partner is tested and this has happened. Then you people go blank. Okay? So please draw these possibilities so that you know that what is she saying and what you have to answer. If I say that she says, I'm diseased and my partner is also diseased, what would you answer? Very well done. Very well done, Jyoti. All would be diseased. Why? Because 100% chance is there. Because we don't have normal. Very well done. Perfect. So this is what you have to do so that in exam, there's no point that you people get confused. All right? Okay. So this was about the sickle cell disease. The outline goes with introduction, agenda, information gathering. Sickle cell disease, remember, tell the effects first, then go to the antenatal, interpartum, postpartum, and here you have to do preconceptional care. So if you divide it in a sequence and you practice it well, you will be as confident and as smooth as Dua was in this station. Very well done, Dua. I'm really happy with the performance. So this 2-week gap, it did work. Very well done. Okay, so sickle cell disease is clear to all of you? Is it clear to all of you? This is how we have to go. It's a sample. 90% and above station has been done by Dua. So whenever you have any ambiguity in that, you can listen to the station and you can formulate your lines as well. So
thank you, Dr. Sada. I'm flushed now. Enough for me.
Thank you very much, Dua. I'm really happy. But Dua, you have set very high standards for yourself. Next time, I'll give you a little difficult station. Be ready for that. Okay?
Inshallah. Thank you.
Right. Thank you, sweetheart. Thank you. So let's do station number 3, and that's going to be with Jyoti. Hello, Jyoti. How are you?
Hi, Dr. Sidra. I'm fine.
I know lots of difficult times, lots of commitments going on, my dear. How had the 2 weeks been? Busy?
Yeah, it was very busy for me.
I totally understand. This had been busy for many.
Week is also supposed to be very, very busy.
I understand. I totally understand. But we'll do well. No problem at all. Okay. So let's go to the station number 3. Everybody, you can hear Jyoti. Her voice is audible to all of you. Yeah? Okay, Jyoti, speak a little more so that everybody can check your mic.
Okay. Can everybody hear me? Am I audible?
Yes, you're audible. Okay, so I'm starting your 2 minutes and let's see how it goes. 3, 2, 1.
Next page, please.
Sure.
Can I have the previous page, please?
Sure.
Can I start?
Yeah.
Hi, I'm Jyoti, one of the doctors in the clinic today. May I confirm your name and age, please?
Yes, hi, Doctor. Doctor, I'm Ellie Paul. I'm 25 years.
And how do you think I can address you?
Ellie is all right.
Highly nice to meet you.
Thank
At the
you.
very outset, I'm really sorry for the clinic which is running late. And I've already escalated the problem and we are looking at it and should be solved soon. But I'm sorry for the inconvenience caused by the late clinic.
Yeah, it's
Secondly,
okay, Doctor. Yeah.
Yes, Ellie, so thanks for understanding. And secondly, you were supposed to be seen by the consultant today, but my consultant is away. And will it be okay for me to see you? And then if you're not happy with the consultation, we can arrange another consultation for you. Is that okay?
That's all right.
Okay, Ellie. So I understand from your notes that you're here because you are having some increased thyroid problems and you're pregnant by 8 weeks. And that's the reason you're seeing us. Am I correct?
Yeah, exactly. Yeah, Doctor.
Okay, Ellie, will you be able to tell me more about your condition?
Yeah, sure. It's been around 5 years that I've been diagnosed by Graves' disease. The things are not bad. I'm having a good control. I just had my thyroid testing. It was around five years back, but now it's been that 6 months ago. I had a little exacerbation in terms of running fever, and they said that it's getting worse. And then they diagnosed that it's actually the Graves' disease, and I had some problem with the thyroid levels because of this disorder. I'm taking propylthiouracil, and this propylthiouracil, I'm fit on that. I'm a little concerned that now I'm pregnant. Is it safe for my baby? Rest, now my condition is all right.
Okay, so we will discuss about the propylthiouracil being safe or not. And I would, before that, will you be able to answer a few questions that I'll ask?
That's okay.
Okay, so may I know whether this is your first pregnancy? I think it's your first pregnancy, yes, it is given here. And you're 8 weeks pregnant.
Yeah.
So how are you doing this pregnancy so far?
It's all right. Initially, they did some tests and they checked my thyroid levels as well. The midwife told me that it's fine, and they did my few booking blood tests and they were happy with that. Ultrasound was done and they told me that yes, the baby heartbeat is there.
Okay, good. Glad to know that. Was this a planned pregnancy?
It is, yeah.
Okay. Congratulations on the pregnancy, and we will discuss the pregnancy further. So may I know if you're on any other medications apart from the propylthiouracil?
Yeah, I've started folic acid, that's it.
Very good. And are you taking 5 milligrams of 5 mg of folic acid?
No, I'm
Okay.
taking 400 micrograms.
Okay. Sorry. Okay, fine. And so any other medical conditions that you have for which you're taking any other?
No, otherwise I'm fine, doctor.
Okay. Any surgeries on your tummy or down below before?
No, doctor.
What about your periods? Were they all right? Or
Yeah.
did you bleed
Yeah.
less?
No, my periods are all right. Whenever I have a little derangement in my thyroid levels, it gets disturbed. But now they're all right because my hormones are set in the levels, normal levels.
Okay. And are you under the care of an endocrinologist or a physician for your Graves' disease?
Yeah.
Okay. And whether medication changed or reviewed or dose increased or decreased now?
I talked to him, but he was saying that propylthiouracil goes okay. I don't know.
That's
so you
correct.
didn't change that, yeah?
Yeah. Propylthiouracil is safe in pregnancy, unless it is of a very high dose. Do you know the dose you're taking?
Not exactly.
Okay, that's fine. So if it is less than 150 milligrams per day, it is fine. However, there is a small risk. Okay, so I'll come to that later. And can I ask you whether you have any allergies to any medication?
No, doctor.
And do you smoke or take alcohol?
No, doctor.
And pardon me to ask, do you any chance of using any recreational drugs?
No, doctor.
And do you know your height to weight ratio?
Yeah, that's normal, doctor. 22.
Okay. And do you know your blood group?
That's A positive.
Okay. Who do you live with, Ellie?
Yeah, I live with my partner. He's very supportive.
Okay, that's good to know. And any history of any illnesses in the family? Any similar conditions?
Not that I know of, no.
Okay. So thank you for giving me all the information. I would just go through your notes and your blood tests, which have been done on your booking visit, and you said it was all normal. Yes. I would then like to discuss the management with you. So it would be basically your propylthiouracil, as I told you, was safe in pregnancy, and you would be continuing with that. You will be looked after by a team of doctors. I would involve the physician or the endocrinologist in our care. And I would also like you to have you done a test of your lungs and heart?
No, not at the moment, no.
So we would like to send you for testing your heart and lungs at the moment. We would check your blood pressure and your urine in this visit. And I will also auscultate your chest to see if there is any increased rate of your heart beating. And I would also like to tell you what we would do during your pregnancy. So we will basically have you said you had a scan where the baby's heart was beating. So apart from the routine care, which will involve doing a scan again at 11 to 14 weeks, and then checking you out for any congenital, for a screening test for Down syndrome, we would do a more frequent scans for you. This is because the pregnancy can have an effect on the disease, and the disease can have a effect on the pregnancy. So the pregnancy can lead to exacerbations in the first trimester, which is the first 12 weeks. You've already crossed 8 weeks. Am I able to be clear to you? Are you able to get me, or am I clear?
Okay, yeah.
So sometimes your disease can be increased by the pregnancy because of the hormones that are produced during pregnancy. and we will have to manage that. Sometimes there can be in the baby, there can be an increased risk of miscarriage, or sometimes the baby can grow small. There can be a preterm birth, which means birth before you reach the term, and there can be increased morbidities in the baby, means increased risks in the baby. So, so we are going to monitor you and the baby by serial scans. We'll do scans and we will find out if everything is going all right for you. Are you able to, am I making myself clear?
Yeah, okay.
And as you go through the pregnancy, you might need to review the medication. So you will be in touch with your endocrinologist, the doctor, hormone doctor, who looks after your thyroid problem. So the dose might need to be increased later on in pregnancy, not in the beginning.
So this is a safe drug.
Yes, this is a safe drug, but there is a small chance of a rare complication can be, it affects the liver, but that is very rare. And it will be guided by the change into another medication will be guided by your hormone doctor who will be looking after you for this condition.
Okay, okay.
All right. Sorry. Okay, so shall I continue?
Yeah.
During your delivery, I would admit you to the, when you're in labor, we would admit you to the, your care would be a consultant-led care, and in a high risk, treated as a high risk pregnancy. And we will monitor your baby continuously and monitor you as well. There can be a chance of increased, it's called a thyrotoxic storm, the increased symptoms of the disease. And we will be able to monitor your baby continuously. And as such, this disease does not mean that you will have a cesarean section. Usually, most of them will be able to give a normal vaginal birth. But there can be some obstetric indications which might lead to increased to a chance of cesarean section. After birth, we will continue the medication, and after birth, we will give you some contraception so that you have time to plan the next pregnancy. And the baby doctors would be involved at the time of your birth to be able to assess the baby for any conditions, a similar condition, or the baby might actually have a low thyroid problem. So the baby doctors will be there to check that out.
Okay.
Am I making myself clear?
Yeah, I get that. So when do I have to come now?
So I would recommend that you come around. We will book an appointment for you for a ultrasound scan at about 11 weeks.
Mm-hmm.
And we will also do the screening for trisomy for Down syndrome soon after that.
Okay.
So we will see you in the next visit.
After how many weeks would I be coming back to you?
So it would be, for the scan, you would be coming at 11 weeks. And for the other test for Down syndrome, it would be, testing would be at around the same time. And you would see me probably around at 16 weeks. So I'll book an appointment for you. Am I clear? And do you have any questions?
No, thank you very much, Doctor. I'm clear.
And also I would give you some information leaflet to read about this condition so that you know what to expect during your pregnancy. Okay. And if you have any questions, I would be happy to answer.
Thank you very much, Doctor. Thank you.
Thank you.
Right, Jyoti. How was the station?
It was very bad. It was very disorganized, and I was a little quite nervous.
I understand.
Wasn't well prepared as well.
No problem. Relax. Or everything will be fine with the passage of time. No problem at all. see, we have to work on those things where we feel we have little shortcomings, right? The problem in the in our preparation goes when we know a lot. Let me tell you your strengths. Your strengths is your communication. Your strength is that you have an empathetic sound. Your strength is that you work in United Kingdom. All these things are strength, but at the same time, they become a trouble when we don't practice ourselves and we start doing the station as we do in the clinic, because here the boundary is 10 minutes time. Okay, the boundary is 10 minutes time. That's the problem. For example, I'll give you an example. When you came to the interpartum care, the line you spoke was absolutely right. Like, this condition does not mean that it would be a cesarean section. We can have a vaginal delivery if no other indications for cesarean sections are there. Generally, women, they have a healthy or the natural birth. So this is a statement which takes you 20, 25 to 30 seconds. If you transform this line and cram it up for your exam, it would be simple. So Ellie, coming to your labor care, if we will plan for the vaginal birth until and unless we have any other indication for cesarean section. We will monitor the baby continuously during the labor. So my point is that we have to be smart enough to communicate one thing in few words rather than 3 lines for the same thing.
Yeah,
that's right. Exactly, because we have got less time. And this comes not with something like, you know, it has to be something like exceptional effort. We just have to cram up lines, simple. We aim for the, and you say always in any of the station, we would aim for the vaginal birth. If we have any other obstetric indications for cesarean section, we'll discuss with you at that time. That's it. So rather than many of the women, they are able to do, this is the same thing when you're saying again, why it happens. I'm not talking to Jyoti only at the moment, friends. I'm talking to all those who are having difficulty. It's not only Jyoti, I know. See, where you people have difficulty, when you people don't know the points to cover. When you people know what is the next point, you immediately do that point and you go to the next. So this comes with rehearsal. And I agree and I know. Don't take this station as an assessment, my dear, because I know that you had been very busy. But for exam, we have to be better, right? For exam, we don't have to leave any loophole for the preparation. That is, you should have, when you listen to Dua station, you will understand that when she had one line in mind, she knew what she has to speak next. So when you know what you have to speak next, definitely the speed comes automatically in your flow, right? It automatically comes in your communication because you know that you've got a lot to cover. When you're slow and you're one thing you're speaking for 3 times, that is that you're not knowing what you have to speak. So touch the point and move to the next. That is just for time management, which we have to work upon, right? Second thing is that when you started, that was a good way of starting and doing an apology. That was very good. The consultant is away. But again, speaking 2 to 3 lines for that, that was good that you said that I've escalated the matter. I would like you to a little speed up, and we'll practice that again. Do the apology again, Jyoti, starting from the beginning. Just say that, Ellie, I apologize at the outset. I would work on your speed, that what is that flow which I want from you so that you practice in the same flow. Just that apology part, please do.
So I have to say, apologize about the consultant not being there as well as the clinic running late.
Both of them, yes. Please do that again so that I can just see that's how the speed is, please.
Okay. Hi, Ellie. Nice to meet you. At the very outset, I would like to apologize for the delay that has been there and the inconvenience that it has caused you. I've escalated the matter and we are looking at it. And also my consultant is not around and I've apologized for the same. And will that be all right if I do the consultation on behalf of the consultant? Is that okay with you, Ellie?
Very good. So this was better. If you go to the recording, previous was a little slower than this. This speed is all right. Okay. Second thing is, don't try to make extra lines for that, because at times when you speak in extra lines, it goes in a wrong direction. Like I would say that I would like to continue the consultation on behalf of my consultant, if that's okay with you, and definitely will fix an appointment with my consultant as well. rather than saying this phrase, my dear, if you're not happy, if you're unhappy today, then I will fix an appointment with my consultant. So I would avoid this statement being, you know, unhappy. That means that myself, I'm thinking that, you know, maybe I'm not that good at the consultation or something. I will avoid this thing. Other way around, a Graves' disease pregnancy has to be seen by consultant.
But I don't understand why we have to sort of apologize for the consultant not being there.
Because it was a consultant appointment.
Oh, okay.
Right? Because it was an appointment with a consultant.
Because we do see patients.
No, we see the patients. That's absolutely all right. But this appointment was with consultant.
Okay.
Right? So if the consultant is not seeing, so of course, then we need to apologize. So it was an appointment with the consultant, right? And rather than saying, if you are unhappy, you say, so definitely next time we'll fix an appointment with a consultant. That's it. So your addressing the concern is done. So that was a good point. At least you did not miss apology, but I want you to be a little speed up. Okay. Now, agenda making was all right. In the entire station, the speed was a little slower. If I compare the entire session, because there were more pauses than I expect.
Yeah, so that's a big problem for me. I'm never able to manage time, and especially it's there because I don't know. I'm not practiced enough. So if I haven't practiced, I don't know what to say next. And
exactly, that's the problem, Jyoti. You've found the problem yourself. The problem is that when you don't know what to say, you take pauses more. When you know what to say. Have you ever seen the algorithm which I make? Why do I make that? So when you're at the top box, you know that what boxes are coming below. So you get speed up, right? The reason is that you get speed up. Okay, I've got a lot to cover and the time is less. So that's the reason. You've found your problem yourself, because when you don't know what to say, you get slower down. So the entire station was slower down in information gathering as well. In information gathering, you started with the Graves' disease. Asking about the Graves' disease was very slow. So how had the things been going? Would you be able to tell me more about the disease? All these things, they take extra time. Be spot on. So may I know more about your condition, Ellie? All right. So then you ask your spot on questions. All right. Then you come to this and you start your history taking. The important point is that you asked about the history and you did congratulations. That was all right. It was a planned pregnancy. Again, you were a little slower at this point. You started your folic acid. You checked about the folic acid. I think it was a fumbling of high dose. Yeah.
I thought it was a high dose, but I don't think so. So you
no, for Graves' disease, friends, is it a high dose?
No, it is not. Probably.
It is not, right? So it is not the indication for the high dose. It has to be 400 microgram. Well done. So medical history, family history. After family history, you came to the gynae history. So gynae history has to be earlier. Again, this is because of lack of practice. I understand. This is something which is not fixed. With practice, we would be perfect in this, Jyoti. So nothing to worry. Okay, with practice, we would be perfect in this, that the sequence would be all right. Then coming to the propyl thiuracil, you started explaining the things here, that 150 milligram and this effect, and then you then you suddenly realized, oh, I've not completed my information gathering. Then you immediately said, no, I'll come to it again. So at least you know that, the template was going wrong. So I'm happy about at least this thing, that you know that you came back to this, though it took time, but at least you realized your mistake. So then BMI, you asked. Antenatal care, mute all, friends. Okay, let me do that. All right. So then you came to the antenatal care, interpartum care, but the time was up. Your one patient safety was missing, and regarding that agranulocytosis, what I would say is that this is a safe drug. However, if you develop taking this sore throat, mouth ulcers, rash, or any unexplained fever, we would suggest that you stop taking tablet immediately and come to the emergency or go to your GP. Because we check the white cell count. If you're taking propyl thiuracil or you notice a yellowing of the eyes and the skin, see the doctor immediately. So these are two patient safety friends which you have to do with the propyl thiuracil. Now, Shaheen has a question that cutaneous aplasia or aplasia cutis, is it the side effect of propyl thiuracil, Shaheen?
But it is written in the that information leaflet.
Okay, this is actually with carbimazole, right? Specifically with the carbimazole. All right.
Okay.
Propyl thiouracil, 2 patient safety things you have to do in exam. Number 1, if she develops sore throat or rash or mouth ulcers or unexplained fever, she has to stop the tablet at once and get her white cell count checked. Number 2, if she gets yellowness of the eyes and the skin, and again, she has to immediately stop the tablet. These 2 things, and she has to see her doctor immediately. So only these 2 things are important for the patient. You should tell her. Yes, my dear.
Yeah, because they have mentioned propyl thiouracil is causing hepatic maternal liver effect is affected in the 2nd and 3rd trimester of pregnancy.
Yes.
But they have not mentioned that cutaneous aplasia is for which medicine, because they have mentioned for both.
Cutaneous aplasia is specifically with carbimazole, remember, and that's written in your Nielsen as well. That's written in your thyroid talk article as well, right? So it is generally with aplasia cutis is with carbimazole and not with propyl thiouracil.
Okay.
Right? So if at all she asks you about the safety and if you have to tell about that, how do you explain about this? How are you going to explain about aplasia cutis?
Patches of absent skin affecting the scalp.
The scalp. You're very good. Well done. If she asks about methimazole, the carbimazole, changing the drug into carbimazole, okay, then you're going to tell about this.
Okay,
so my final suggestion overall is that firstly work upon the speed, Jyoti, and it has to be a little quicker because otherwise it would be a problem.
Sorry to interrupt you, doctor. This carbimazole nowadays they're not giving, so we have to mention, or we continue with the propyl thiouracil?
We would not change the drug. We would say that I'll connect you to the thyroid doctor and he would suggest the best drug. If everything is going all right on propyl thiouracil, he may continue. If any side effects occur with this drug, he might discuss with you the alternative. That's the best part of maternal medicine, that you don't have to stop any drug, you don't have to change any drug, only urgent referral. That's it.
Okay, thank you.
You have to mention if some complication occurs, so he might talk to you about the alternative drug. That's it. Your job is done. All right. Okay. And second thing which I was talking to you about was, Jyoti, that I know things are going tougher, but at least 1 station a day, and that too has to be better than the previous one, so that, you know, things they take time. I would make a suggestion. See, I know that 4 to 5 months, maybe the exam is planned in February. Up till now, it is planned in February. And this would pass in, believe me, it would just fly over, because after the exam stations, you people have to do all the 3 books as well.
But
so
that makes February. Have they said February?
So see if it comes.
Yeah, I mean, it's expected, like we can think in our minds that it can be February, yes.
Exactly. So see, the time would fly. You all have to at least do 1 station. The reason is, again, I would tell you that immediately in 1 month gap, they will give you that exam is going to be here at this time. Only those people who are prepared will book the exam. The ones who are taking it easy won't be able to prepare in 1 or 2 months. So everything would be ready. Everything would be ready with you. 1 station a day doesn't take much time. But closing books and not doing a station, believe me, you'll forget even the basics. And starting from 0 takes lots of effort. So at least 1 station a day, my dear. Working on your time management, please. Whenever you're stuck up in the time management or you're thinking, because the lines, you know, it's only that practice of these lines, right? Only practice of these lines, which is important, which you have to do. Communication with the patient, I like your tone. I like your communication, but at times you get deviated from the main track. You go on the side roads, which I have to, you know, make you go have your focus in the center.
Yeah, I realize it myself, but I'm not able to correct it without practicing.
Yes. So practice that, you know, write your bullet points. In the template, write your bullet points that I have to cover this. Other than this, I don't have to speak anything extra. When you'll cut down your extra speaking, your communication would improve. Jyoti, I know people that for whom I have to work on their communication in terms of language. See, you have that strength in you. So why not to use it in the right direction, my dear? Why to speak extra when it's not required? Okay, you can do it. Everybody has his or her own positives and the plus points. So we have to polish our positives and work on our weaknesses so that we stand on that passing strata. Okay? Graves' disease history was all right. About other history was also fine, but it was a little up and down, fumbling in the history, and took a little more time as compared to the general history, which has to be done. Safety of propylthiouracil and carbimazole has to be done. Aspirin 75 mg, friends. Please tell me. Very good, Sabiha. Please do at least one station a day, Dr. Sabiha. So is she a candidate of aspirin 75 milligram, friends, in pregnancy, which was not started by Jyoti?
Yes, I think.
She is
Because
first
there is
pregnancy
risk.
and comorbidity. Is that Graves' disease a indication? Comorbidity?
Exactly. This comes in the autoimmune risk and autoimmune diseases, and it is a major risk factor as per the NICE guideline for starting aspirin.
Yeah.
Right? So this has to be started. This is your patient safety. Side effects of propylthiouracil was not mentioned, as agranulocytosis I told you, and yellowness. Jaundice you did mention, my dear. But a very important thing is that sore throat, mouth ulcers, rash, and unexplained fever. So you have to do that as well, okay? So you were open and honest about the effects, but effects were a little less. If I would be coming to the effects, I would say, Ellie, I would like to tell you that mother, they can have raised blood pressure in this condition and having proteins in the urine. The baby can be smaller in size than duration of the pregnancy. There can be worsening of this condition. We call it as thyroid storm. And the early pregnancy loss can also be there. The pregnancy can have, the condition can be aggravated in the pregnancy. At times, because of these medications, liver also gets affected, and the chances of having early birth in the due date is also there. For the baby, early pregnancy loss can be there. With certain drug like that of carbimazole, there can be deficient scalp effect of the baby as well. And the baby can be smaller in growth. The weight can be less as well. Because of these medications, they can cross the afterbirth and can reach in the bloodstream of the baby. Therefore, there can be little fluctuations in the thyroid hormone levels in the baby as well. This point is very important. Baby can be born hypothyroid. Am I clear? Baby can be born hypothyroid, for which the baby doctor will take care of the situation. Taking you through the pregnancy journey, it's going to be a team of doctors taking care of you, especially the hormone doctor and my consultant with a specialized midwife and a nurse. Folic acid would be continued till first 12 weeks of the pregnancy. We'll ensure that you have all your booking tests. I'll go through all the tests. If it's already done in the history, then you'll go through that. The mid-pregnancy scan, screening for having proteins in the urine at every visit. The medications would be continued, and you'll have your regular visits with your thyroid doctor. Along with that, in each half of your pregnancy, we will check for the thyroid levels to see that the drugs they have, they're good control on your thyroid levels. It is going to be a consultant-led unit birth. The baby would be monitored with the baby heartbeat continuously. We will aim for the vaginal delivery. If we have any other indication for cesarean section, we'll discuss with you in detail. Once the baby is born, we'll be seen by the baby doctor. We'll encourage you to the breastfeeding, Ellie, and we'll discuss the appropriate contraception for you. After you get delivered, we'll refer you to the thyroid doctor, and the baby doctor will review the baby as well, and will talk to you in detail. So this is the information leaflet, and we'll connect you to the support group as well. So it was not that bigger a station. It was not that bigger a station, but because of a little lack of management of time, things they went a little up and down, but I'm sure we'll do it perfectly. It is at least once in each trimester, Nadra. It's one in each trimester. I mean, first trimester, second trimester, third trimester. So at least once. So more often if it's not normal. Yes, Harshaba, that's why I said it is a fluctuation. When I say fluctuation in the thyroid hormone levels, that means it can be up, it can be down. Hypo and hyper both can be the baby. Right, Harshaba? That's why the statement I used, that there can be fluctuations in the thyroid hormone levels in the baby because of the medications mom is taking. All right. Nadra, did I clarify your point? They say that at least once in each trimester, it has to be done, my dear. More frequent if the values, they are not normal. This is how you speak up. Clear? Right? So if I go to the outline, it has to be introduction, agenda, information gathering, effects on the mother and the baby, antenatal, intrapartum, and postpartum care, address the concerns, follow a plan, PIL and support groups. Now, in this patient, we won't check for the thyroid antibodies, Nadra. What does the thyroid antibody mean? Dr. Sabia, whenever it comes to applied clinical knowledge, knock on to Dr. Sabia and Athiya and Sarvat. And why do we check thyroid antibodies, Nadra? In this patient, there's no requirement.
No change of management.
Exactly. In this patient, there would be not be any change of management. Nadra, what is in your mind when you say about the thyroid antibodies? What is at the back of your mind, my dear? Because she's already diagnosed with Graves' disease. Yes.
Ma'am, actually, it's written that thyroid antibodies will be done to monitor the baby, because in case she does have thyroid antibodies, we'll have to look for goiter of the baby and the fetal heart of the baby on the ultrasounds, and then monitor after the birth of the baby for hyperthyroidism.
No, it's not controlled. Hyperthyroidism not controlled, then we're gonna go for that management. That's what written.
Exactly. Right? For this patient, it's not required.
We were reading the leaflet.
Did you people understand?
Yeah.
For this patient, it's not required because she's on propyl thiouracil with a normal thyroid. And in exam, they won't give you multiple things being deranged because they know it's 10 minutes, right? So if it is deranged, then you're going to go to that. Otherwise, it's not something which is required in this case at all. Yes, but checking that propyl thiouracil is being given in the right dose. Yeah, in every trimester, you have to do one thyroid function test. More frequently if the values are deranged. That's it. Clear? Thank you very much. Thank you. So, Jyoti, you have to stay connected to me, my dear. Every day, please just drop in a message that, Sidra, I've done this today. I'm working on this. Starting from introduction, we'll work on, bits and pieces so that we don't get overburdened by this. Like, take 5
Dr.
days.
Sidra?
Yes, Dr. Sabia, please. Yes.
Dr. Sidra, but when the patient has history of Graves' disease and she has treated well, either because with the surgery or with the radioactive iodine, in that case, you have to check the antibodies, because patient is euthyroid or even hypothyroid on thyroxine, but there are antibodies are there. And in that situation, these antibodies, they have traps. They can transfer because they are transferred through the placenta and they affect the babies. Even the mother is euthyroid or hypothyroid.
No, so my point is that it is going to be, the baby would be checked, right? The baby would be checked by the baby doctor. If she is euthyroid, why would we check frequently antibodies? Because the antibodies are already
not frequently.
There. Exactly.
No, not frequently.
Nadra's question was how frequent we have to check for the antibodies.
No, not frequently. At least once we have to check whether there is higher level of antibodies or not, so that postnatally baby can be, that pediatrician should know the status of mother's antibodies. Only once can be, enough.
Yeah.
What I would suggest is she's a diagnosed case of Graves' disease and she's having a good control. So check for the thyroid levels. Further investigations, you can simply say if the thyroid doctor would offer a few investigations for the baby well-being, and the baby doctor will talk to you as well. So never go into that extreme medical thing which you are not sure of. Be very diplomatic somewhere.
Yeah, you are right. You are exactly right. We should be diplomatic. Whatever the situation is there, either the change of the medication or either conditions and all, we have to shift the patient to the endocrinologist.
And whenever you think that she asks for some other test, because it would never be a score that you offered the antibody testing or not, because you are not
you are right.
This patient. So always say that, yes, we are going to refer you to the thyroid doctor if some additional tests or investigations or change in dose or change of medication is required. He would do that and he'll talk to you in detail about that. Your job is done.
Yes. Yeah, you are right. Exactly right. Agreed.
Antibodies, because we are not going to change the management in any way.
Exactly. So why to take another 30 seconds to, tell her that these antibodies and this is what they do? Yes, you have to tell about that baby can have fluctuations in the thyroid level because of the treatment of the mother. So that's it. Your job is done. All right. Okay, very well done. Thank you very much, Jyoti.
How do we explain perinatal mortality to the patient?
The baby.
Perinatal.
What is the definition of perinatal mortality? Perinatal mortality means either it can be a stillbirth or the first 7 days death of the baby.
Okay, so do
Right?
we say that straight?
So what we say is, so what we say is that in extreme cases, the baby can die inside the womb or in the first few days of life as well. That's it.
Okay, thank you.
Okay.
Thank you, Dr.
You're welcome, my dear. You're welcome. Keep going, Jyoti. We'll work on this, and definitely even in our upcoming stations, we would be better. Okay. Thank you very much, my dear. Thank you. All right. So let's go to the station number 4. And if I'm not wrong, we've got Archana here. Hello, Archana.
Hello, ma'am.
How are you?
I'm fine.
How is the COVID situation, Archana? Better in India or still the same?
No, it's worsening, ma'am.
Don't tell me again. It was the second wave
but at my place, I think we are getting herd immunity now.
Yeah, now you people are all exposed to that thing. I can understand.
Yes.
So let's hope for the best. I hope things they would get better soon. So let's begin with the station. Yeah.
Yes.
Okay, let me start your 2 minutes time, and let's begin, my dear. Go ahead.
Okay, next slide. Next. Ma'am, previous one. Hello, ma'am. I'm Dr. Archana, one of the exam candidate. I had read the scenario and I'm ready for the structural discussion.
Okay, so what is your summary of the case, Archana?
Ma'am, my patient, Mrs. Julia Robert, she is 33-year-old, who is 9 weeks pregnant and is known case of chronic kidney disease, came for antenatal checkup. She is gravid at 3, para 1 and 1 abortion. Her first pregnancy ended in spontaneous abortion. And her second pregnancy, she had gestational diabetes, which was managed with metformin and had vaginal delivery at 38 weeks. Currently, she is 9 weeks pregnant. This is her planned pregnancy. With regard to her chronic kidney disease, it's stage 2 chronic kidney disease. Her serum creatinine level is not given, but her GFR is 79. Currently, she is on aspirin, vitamins, and enalapril. Coming to the assessment, I would like to do her general examination to check her BMI, pulse, blood pressure, and temperature. I will also ask her for any symptoms of chronic kidney disease like any history of weight loss or poor appetite, any shortness of breath, or any history of swollen ankle, feet, or hands, and any blood in urine. As a part of recommendation, I will review her recent renal function test. I will also want to review her booking blood test, like they are done or not, like HIV, HbSAg, or VDRL. I will see her complete blood count. I will do her blood group and RH type, antibody screening, and midstream urine. I will book her pregnancy under multidisciplinary team, which will include team of doctor like consultant obstetrician, her renal physician, hematologist, neonatologist, and senior midwife. I will counsel her regarding effect of kidney disease on pregnancy and also the effect of pregnancy on her kidney disease.
All right. So can you tell me that what are the possible complications in this case?
The complication can be both maternal and fetal. Coming to the maternal complication, it can have deterioration of renal function with advancement of the pregnancy. It can lead to miscarriage. She is high risk for preeclampsia. It can have recurrent urinary tract infection. She is prone to development of anemia also. Venous thromboembolism can be there. It can cause polyhydramnios. And as in her second pregnancy, she had gestational diabetes. Now she is also high risk for gestational diabetes in this pregnancy also. With fetal complication, there can be miscarriage, fetal growth restriction, there can be preterm labor or stillbirth.
All right. So what were the investigations you would like to order for your patient?
First, I will do routine blood test like booking blood test, her complete blood count to look for her HP, platelet, and white blood cells. Viral marker like HIV, HBsAg, her VDRL, midstream urine, blood group, and RH type. I will also do kidney function test. As in pregnancy, glomerular filtration rate is not recommended due to misinterpretation of values as there is increased blood flow, renal blood flow. So I will like to do her serum creatinine level and urea level. According to her serum creatinine value, she can be grouped under mild, moderate, or severe form of the disease. If her serum creatinine value is less than 125, I will call it as a mild form of the disease. If it's between 125 to 180, it is moderate, and if it's severe form, the values might be more than 180. I will also check for the VTA prophylaxis, but as right now, according to her report, she doesn't need any VTA prophylaxis. But if it's nephropathy or nephrotic syndrome, her VTA score will be 3 according to the Green Top guideline of VTA. So we will start her on LMWH from 28 weeks of period of gestation to the 6 weeks postpartum. As she is CKD2, which is major risk factor for small for gestational age, according to the SGA Green Top guideline, I will do her serial growth scan with umbilical artery Doppler from 26 to 28 weeks onward.
Okay. What is your management plan for this patient of yours?
As she is high risk pregnancy, I will manage her under MDT, which include consultant obstetrician, renal physician, hematologist, neonatologist, senior midwife, and dietitian. Her antenatal care will be done with booking test, dating scan, screening for Down syndrome, anomaly scan at 18 to 20 weeks, serial growth scan with umbilical artery Doppler from 26-28 weeks onward. I will review her medicine. I will continue her folic acid. I will put her on aspirin. As enalapril is not baby friendly and safe antihypertensive will be started after consultation with renal physician and my consultant as a joint decision. Okay. As she is high risk for GDM, her 2-hour 75 gram glucose test will be done at booking and will be repeated at 24 to 28 weeks. As she is prone for recurrent UTI, prophylactic antibiotic may be considered. If her causes of CKD is due to inherited kidney disease, I will connect her to the genetic counselor. Regarding the labor and delivery, she will be under consultant-led unit with availability of renal physician. We will aim for vaginal delivery. C-section is only for obstetric indication. If as she is a known case of CKD, fluid management will be done. Continuous electronic fetal monitoring will be done. As per postpartum care is concerned, management of prophylactic third stage to avoid PPH. encourage her for breastfeeding. PT assessment again will be done. We will provide her with detailed contraception advice and change of antihypertensive with the help of renal physician again. And we will review with neonatal for inherited disease.
All right, well done. So do you have anything to add in any of the questions? You've got 30 seconds more.
Right now the cause of renal kidney diseases is not known. I will also want to evaluate for the cause of CKD, as it can be due to glomerulonephritis, reflex nephropathy, diabetic nephropathy, SLE nephritis, or polycystic kidney disease, and we will search for according to the cause.
All right, if it's an inheritable cause, so you'll
connect her to the genetic counselor.
Oh, very well done, very well done.
Thank you, ma'am, for your time.
Yeah, 10 seconds or more, right?
Thank you for your time.
Thank you very much. A wonderfully done station, Archana. Very well done. Very well versed station. Group D, very good. Such a beautiful information, and that too in a sequence. No problem in your applied clinical knowledge. Very well prepared. And the way you were taking the Doppler, believe me, none of the students up till now mentioned Doppler in this case. Do you people remember that this is an indication for Doppler? All of you? Did you people remember that this is an indication for Doppler? None of the students in the last few days did Doppler for this patient. This comes in the high risk. I have nothing to add. Beautifully done SBAR. Did you people see that SBAR, how Archana did the situation, background, assessment, and recommendation? Beautifully, she took the SBAR in a sequence, identifying the women's name. Julia Robert, 33 years, 9 weeks pregnant with chronic kidney disease, and she has come for the antenatal care. She is gravida 3 para 1, a +1 with chronic kidney disease reported for antenatal care and previous history of miscarriage at 7 weeks of gestation 5 years ago. She had a vaginal delivery at 38 weeks, complicated with GDM, received metformin. Currently at 9 weeks pregnancy, coming for booking visit and a planned pregnancy. So provided to me is her GFR at the moment. Would like to do her general examination, BMI, pulse, blood pressure, temperature. Would like to assess her symptoms for chronic kidney disease like weight loss, poor appetite, shortness of breath, swollen ankles, feet, hands, blood and urine. The test which I would like to know is about the recent renal function test, the booking blood test, the HIV, hepatitis B, syphilis, full blood count, the blood group, and the Rh antibody screening with the midstream urine. Will counsel on the effects of the kidney disease on pregnancy and pregnancy on the kidney disease. Beautiful flow, Archana, the way you were speaking, no fumbling at all. You had read the chronic kidney disease beautifully. I just want the same flow in the structured discussion as well in exam. Baseline, renal function, proteinuria, review with renal function. Thromboembolism risk assessment was a perfect point which you touched where students, they have a difficulty. I would like to do her microbiology screening, midstream urine, hepatitis B virus, HIV, and HCV. Would like to offer her 400 microgram folic acid and starting aspirin. Wonderful. This was a major risk factor. Dating scan and down screening. The possible complications, always remember, one of my Malaysian students, she was doing a station and she did the complications like enumerating. So ideal way is always dividing it into maternal and fetal. Deterioration of the renal function with pregnancy, miscarriage, preeclampsia, urinary tract infection, anemia, polyhydramnios. Fetal complications of miscarriage, fetal growth restriction, preterm labor, and stillbirth. And I was very happy on picking up that you want serum creatinine. Why did she want serum creatinine, friends, when GFR is given? Why did she ask for the serum creatinine? What was the reason?
Serum creatinine is a predictor of the outcome. It is the most important predictor of the outcome. GFR is not reliable.
Exactly. GFR is the biggest predictor, but in a non-pregnant state, remember, in a non-pregnant state, GFR That is the best predictor. And that is why I gave GFR in the exam station investigation. So she asks for serum creatinine and wonderfully done, mild, moderate, severe renal impairment, Archana. This is how the practice speaks, my dear. This is how it speaks. You were very good in part 2 as well. And I know that you're a hardworking student. I know that communication is a problem because of the language, but did you people notice? Jyoti, she is a perfect example. Her local language. Archana, what is the name of your local language, my dear, which the kids speak and I keep on hearing on telephone? What is the name of the language? Archana, what
Marathi.
do you say? Marathi, yeah. So, you know, when... Marathi, right. She keeps on speaking that and in such a fluent that I always say that how in the world you're going to do a station in English. But can you see the difference? That she has a difficulty in the language. She has that difficulty in speaking, but when it comes to practice, definitely everybody can improve that. I will give you an example that one of my students, she was from one of the Arabic countries, and she used to speak H from that of, you know, that throat sound which we take out when we speak the Arabic language. And I used to turn her always that, you know, when you have to speak English, you have to speak in its own manner. And believe me, she passed in first go. But I would say that she was adamant that I have to pass. She had that enthusiasm that I have to pass. I gave my 100%, but in return, I would say that she gave, in fact, she used to do a station 3 to 4 times before coming to me that, Sidra, I have to be perfect. I have to pass this station, this exam at any cost in this go. I know I don't know English, but I have to pass this. So I would say that I have seen Archana grooming. She has worked a lot. She needs to put in more effort than others. But if she can do that, today she has proven that when you know the knowledge and when you practice that, you definitely come to that mark, right? So this is very good attempt, Archana. I'm very happy, my dear. This is what she spoke. This is what I want to clarify to all of you. Please remember, every chronic kidney disease is not a score for venous thromboembolism. Remember, venous thromboembolism is only a score when it comes to nephropathy or nephrotic syndrome. Please don't get confused in exam. Otherwise, it's not the scoring. You just do the renal assessment. The point is, remember this part, that whenever it's a renal impairment, directly go to the Doppler at 26 to 28 weeks. Students, they forget that. That's why I've placed these 2 charts that you should not forget. Students that remember it's only a growth scan. No, a renal impairment directly is a Doppler. It's a major risk factor for SGA and starting aspirin as well. Perfectly done. Every point was 100% perfectly touched. Antenatal care, you went through the MDT. Best part was that she did not focus only the CKD. She did remember that this patient had GDM as well. So doing an OGTT in this pregnancy. This is how you prepare your template and you always remember these things. Changing enalapril was perfect. In the management plan, you mentioned that cause of CKD is very important because if it's a hereditary cause, you have to connect her to the genetic counselor. Glomerulonephritis, reflex nephropathy, diabetic nephropathy, SLE nephritis, polycystic kidney disease as well. The management plan, as she's high risk for 2 things, gestational diabetes mellitus, because in previous pregnancy she had one, and preeclampsia. So anomaly scan she did after this duration, OGTT, yes. High risk for SGS or umbilical artery Doppler, serial growth scans, genetic counseling, if at all it's an inherited condition like adult polycystic kidney disease. Maintenance of blood pressure on a safe antihypertensive, changing enalapril less than 140/90 you have to keep, and recurrent UTI, consider prophylactic antibiotics. Intrapartum care would be consultant-led, aiming for the vaginal delivery, being high risk for cesarean section, delivering at term if no complication. Fluid restriction may be considered, considering her renal status, a regular monitoring of a cardiac status, temperature record, a continuous CTG. If she is on immunosuppression, then IV hydrocortisone would be checked for this patient. Encouraging breastfeed, VT assessment, review of medications, contraceptive advice, and neonatal review if inherited disease is the question. Very well done. All of you, please just follow this template. Just note down these because this is a salt station. 2 Stations from kidney, renal system are very important. Maternal disorder, renal transplant, and also the chronic kidney disease. Right? So this is what you all have to remember for exam, so that you just go smoothly in exam for all this antepartum, interpartum, and postpartum care. All right, very well done. Actually, it's a clear pass station, my dear. Dr. Sabia took a very good start in a structured discussion, my dear, and you followed the same pattern. Very well done. Flow was perfect, communication was perfect, the pauses were perfect, applied clinical knowledge was perfect, and you managed in a perfectly way. It's a total pass station. Very well done. Very good, my dear. Did you people understand the chronic kidney disease? Yeah, that how the things would be in pregnancy? Yes, Dr. Sabia, please.
Dr.
Your voice is
renal
getting
transplant patient also comes in structured discussion or SPT? Renal transplant.
Renal transplant and CKT both has come up till now till structured discussion.
Okay.
Up till now, both the stations were a structured discussion. All right. Okay, thank you very much. Thank you. All right. Okay, so done with station number 4? Great. So can we take just 2 minutes break? 2 minutes break, and then we'll just continue with station number 5. It's going to be Dalia. Dalia, are you back after the duty?
Yes, Dr. Sidhu. Hi.
Okay, okay. Guys, just take a 2 minutes break and we'll start station number 5. All right?
Okay.
Okay, get hold of your coffee and we'll start just in 2 minutes time. Thank you. All right, friends, everybody back? Yes? Okay. So do we have Dalia here? Dalia, please check your mic.
Yes, Dr. Cedar, I'm here.
Thank you very much. Thank you. So how was the duty? I hope it was not very tough.
It was
right,
very tough.
Okay, okay. Let's begin with your 2 minutes, huh?
Yes.
All right. Okay, so let's start.
Okay, next. Okay, next. Okay, next. Okay, I'm ready. Hello, I'm Dr. Dalia. I'm one of the treating doctors for today in the antenatal clinic. May I confirm your name and age, please?
Yes, hi, doctor. Doctor, I'm Rebecca Williams. I'm 29 years.
May I, how would you like to me to address you?
Yeah, Rebecca's all right.
Okay, well, Rebecca, and I understand from your case notes that you are here today as you are trying for a baby and that you are diabetic. Am I correct?
Yeah, exactly, doctor. Yeah.
Well, it's very good that you are seeking advice before getting pregnant, as planning for your pregnancy will reduce the complications for both you and your baby. So, of course, we are going to discuss all your concerns and we'll come together to a mutually agreed plan of management. But before this, would you mind if I asked you a few questions so as to know more about you?
That's okay.
Okay, can you tell me more about your diabetes? Since when you have this condition?
Yeah, doctor, I was diagnosed around 10 years back, and I'm taking insulin. I take an insulin in the morning, then in the evening, and the things are going fine. My home record is all fine for last 1 month. So now we plan to have a baby. So I thought it's better to just complete the family now.
Okay, and have you had any recent admissions to the hospital, Rebecca?
No.
And have you had a recent checkup with your diabetes doctor?
I had it around 3 months back.
Mm-hmm. And how was the results?
Yeah, that was all right. He adjusted my insulin at that time. The things are fine. He asked me to make a home record, which I've just done for 1 month.
Okay. And have you done any kidney or eye checkups?
It was done 6.5 months back, doctor.
And the results?
At that time, it was normal.
The results were, sorry?
It was fine. It was normal. Examination was fine.
Okay, but it was 6 months back.
Yeah, 6.5 months. Yeah.
Okay. Okay, so have you ever been pregnant before, Rebecca?
No, this is the first time you're planning for a baby.
Okay, and have you started any folic acid yet, or you haven't?
I've started folic acid. I'm taking 5 milligrams
per day. Okay. Do you know your blood group?
A positive.
Okay. And how about your periods? Are they regular?
Yeah, periods are fine.
Okay. And are you up to date with your smears?
Yes, smears are okay.
Okay. And are you following with your GP for any other conditions?
Otherwise, I'm all right.
Okay. And are you allergic to any medications?
No, I'm not.
Have you ever had any surgeries before in your tummy or from down below?
No, never surgery.
Do you have a family history of a similar condition, Rebecca?
Yeah, my parents, both of them are diabetic, but otherwise they're fine as well.
Okay. What do you do for a living?
Yeah, I have my own online business.
Okay. And with whom do you live?
I live with a partner, and we are a very, very happy couple.
Okay, so everything is okay at home?
Yeah, it is, yeah.
So do you smoke, Rebecca?
No, I'm not doing that because I'm planning a baby, yeah.
Okay, and do you drink alcohol?
No.
And pardon me if I ask, do you take any recreational drugs?
No, doctor.
Have you ever felt down, Rebecca, in the last 4 weeks?
No, I'm all right otherwise, yeah.
Okay. Thank you, Rebecca, for sharing your information with me. Is there anything else you would like to add?
No, that's it. I would just like to know that I just wanted to get pregnant. It's okay. I'm practicing condoms at the moment. I stop it now.
Okay. Well, from your history, Rebecca, and also from your from your tests, I strongly advise you to start a reliable method of contraception for at least the upcoming 3 months.
3 months? Why, doctor? Yeah, my levels are fine.
Because we depend upon what's called the hemoglobin A1C in order to know the level, how much you are controlled in the last 3 months. And the level of this test is, in your case, high. So you will not be able to get pregnant for the upcoming 3 months till you control your blood sugar levels. So we need to book you an appointment with a diabetes specialist who is expected to do a full check on you and asks for some tests for you and change the doses of the insulin you're taking so as to control your blood sugar level, okay? And also we need to offer you an eye and kidney check. Are you following me, Rebecca?
Yeah, but what would happen if I just get pregnant now? Because I'm already 29. It's getting late.
So the problem, Rebecca, is that if you got pregnant with these tests and these results, there is a high chance that you will have a miscarriage. And if you haven't got a miscarriage, there is a high chance that your baby will have a congenital anomaly or a congenital malformation.
Okay.
Are you following, Rebecca?
Yeah, okay. So how would be the pregnancy otherwise?
I will go through the journey of pregnancy. You haven't got any information about diabetes during pregnancy, right?
No, I just wanted to know that how would be my pregnancy care.
Okay. So just I would like to tell you about the risks that will be on you because of the pregnancy during diabetes. There may be problems that occur to your eyes or kidneys. You have any changes in these if you have any complications in your eyes or kidneys, this will get worse. And for your baby, as I told you, there is a risk of miscarriage and there is a risk of abnormal development or the congenital anomalies that may come to your baby. And this occurs especially if your blood sugar, as in your case, is not well controlled. Okay? So we are going to reduce the risk of these things to happen by adequately controlling your blood sugar. Okay?
I get that. All right. So
continue using folic acid, and you should not stop the folic acid. You should continue to take it all through the 3 months till you get pregnant. Okay?
Yeah. Okay.
Well, the most important thing that the management of your case, Rebecca, will be you will be cared for by a team of doctors, a consultant obstetrician, and the diabetes specialist, and the specialized midwife, and a specialized nurse. Are you following, Rebecca?
Yeah, I am.
And you will be followed up in a consultant-led care unit, okay? And you will be given a monitor and a testing strips if you don't have them. And you will be given information about how you can use them and monitor your blood sugar at home. And you will be told the target levels that we desire. And also you will be given testing strips in urine that tests what's called ketones, because if their levels are high in urine, it means that your blood sugar is not controlled. Okay. Also, the diabetes specialist will discuss with you the suitable doses, and the dietitian will give you information about the suitable diet for you. And you are going to have a kidney and eye checkup before you go through this upcoming 3 months before you go. And you will have regular checks and scans with an organized timetable for the appointments to make sure that you are well and your diabetes is well controlled and your baby is fine. You will have scans. Regular scans, early scan, the early dating scan, and the scan for screening for Down syndrome, and the scan, the 18 to 20 week anomaly scan to check that your baby has no congenital anomalies. And also you will be having from 28 weeks and on, you will be having serial growth scans in order to monitor your baby's growth. Are you following?
Yeah, I'm understanding, doctor. Yeah.
Okay. During labor, Rebecca, you will be advised to have your labor in a consultant-led care unit. It will be preferred to be induced and will be induced during the week 37 or 38 of pregnancy. You will be advised to have your baby earlier if there are complications that occur during pregnancy, earlier than this date. If any complication happens, such as high blood pressure, or if your baby's growth slows down, and your blood sugar will also be monitored during your labor. After labor, Rebecca, we will check also your blood sugar levels and you will be advised to start breastfeeding your baby as soon as possible after birth. And you will be advised to reduce the insulin doses to avoid sudden lowering in your blood sugar level. And you and your baby will stay in hospital for at least 24 hours after birth to check that your baby blood sugar is normal and the baby is feeding well. And after returning back to home, Rebecca, you should go back to your regular checks with your diabetes specialist. Okay, and we will also discuss with you the suitable contraceptive method for you. And it should be a reliable contraception to prevent any unplanned pregnancy. In your case, it's preferred to be the cup coil. Okay?
Okay, what do I have to do now?
Oh, now I will give you a patient information leaflet, Rebecca, and we'll give you an appointment with the diabetes specialist and with dietitian, because they are going to put the plan for you regarding the medications and regarding the diets that you should follow. And also will arrange an appointment with my consultant in order to talk to you after you revise all the information that I have given. I'm giving you in this patient information leaflet. Is there anything else?
When would be my next test, doctor?
But pardon?
When would be my next test to check for the sugar control?
Yes, there will be a blood test. Yes.
When?
He will just check these the medications and will change the doses of insulin, and then after 3 months he will repeat the hemoglobin A1C test again and see how is your blood sugar controlled through these 3 months.
Okay, all right. Thank you, doctor.
Okay, thank you.
Thank you very much. Thank you. Yeah, how is it, Dalia? Long station.
Oh yes.
It's okay.
Yes,
it's okay.
very long.
I know it was a long
It
station.
was running game. Yes, I know that many things I didn't say everything.
No. There were many things which you didn't say, but there were many things extra which you said as well. So both way, right? Okay, all right. So nothing to worry. With every passing day, we are improving. I know you started just your preparation in few months' time. So don't compare yourself with all those who are a little more fluent, because see, every patient, every student, when you manage the station, every student has a different baseline. So I have to grade you for your own baseline. I would definitely say, because Nadra or Dua or all those, they have been preparing way too earlier. So definitely there's a difference when I polish them. That's a difference between you and them. So nothing to worry, okay? So we'll definitely reach that time. The best part is that now we have ample time to work more harder, okay? So
okay.
Did you manage to attend the meetings this time? Or were you busy?
The meetings, yes.
Mini group?
Yes.
Yeah?
Yes.
Okay. So Nadra, work on the time management for Dalia as well, please. When you people are doing, give her a little tough time on this. In fact, let her complete her station in 9 minutes rather than 10 minutes, so that she is a little quicker. Okay, so when you work on this element that she has to be little speedy in her presentation, definitely she'll work on her speed. And one more suggestion, Dalia, what you have to do is, my dear, keep a timer in front of you while doing a station.
Mm-hmm.
What would happen with this? Your flow or your communication would speed up.
Okay.
Okay, Dr. Sabia, you have to do this as well. Jyoti, you have to do this as well. Whenever the station starts, put the timer on and put it in front of you, so that every now and then you have your eye on the timer and it tells you that, you know, where you have to be quicker. Now you're getting late for your station, right?
Yes.
Clear? Very good. Well done. So let's begin. Introduction was fine. In the entire station, like I commented upon Jyoti's as well, Dalia, speed was a little slower, sweetheart. We have to work on speed. See, we've got only 10 minutes. So the idea, the way you communicated would be perfect in a clinic, but it won't be a suitable thing for the examination point of view. We have to be a little quicker because we have to fight against time, okay? We have to fight against time. So
Yes.
you know the things, but a little quicker, my dear, keeping time management in front of you so that we don't practice extra words, okay?
Okay.
So your agenda making was fine, but try to say, don't say type 1 diabetes. It is suggested that we say that you have a condition, type 1 diabetes, all right? Information gathering went fine, but it was slower. It was a little more pauses in that. It took 6.5 minutes. 6.5 minutes. So we have to shrink it to 4 minutes, Dalia.
Okay.
We will do it together. Nothing to worry. We will do it in 4 minutes and we'll show everybody that yes, we can do it in 4 minutes. All right. Everybody starts with a longer history and we'll shrink it up to bring it in 4 minutes quicker, one after the other. One after the other questions should be coming in your mind and you should be uttering it like spontaneously. All right. And there was a point that our home record was fine. I would try to touch that point as well. We'll just tell you in a bit. You did ask about
was
yeah. So you did thank
yes,
me
but for the last 1 month only.
Yeah, so that was
The
normal.
hemoglobin was 8, so
So eye and kidney checkup you did recommend in the end as well because 6.5 months back it was done. That was good. Antenatal care, intrapartum and postpartum care, we little deviated from the from our template. I suggested earlier as well, would say that again, that whenever you are completing with the information gathering, immediately come to the effects of diabetes to the mother and to the baby. Because you started telling me about the preconceptional care. So first we will tell about the effects on the mother and the effects on the baby. And then we'll come to the antenatal, intrapartum and postpartum care. After completing that, we will come to the preconceptional care. So here
I think I mentioned that there are risks for the mother and the risks on the baby.
You did mention,
I think I mentioned that point.
my dear, but that it came a little late, like after antenatal care. We have to do that after information gathering.
You wanted the first.
Exactly. This has to be first, and then you come to the antenatal care. One more thing, according to the NICE guideline, the HbA1c is repeated every month, not after 3 months.
Okay.
Every month we have to repeat that if it's deranged. And you're absolutely right, according to the NICE guideline, if 6 months have passed in the pre-pregnancy patient, 6 months have passed for the retinal and the renal checkup. Yes, it is going to be then after, you have to do that prior to the pregnancy. Okay, if 6 months have passed. So that was a good thing that you did offer. That was very good, my dear. Congenital anomaly is a jargon. You say there can be developmental problems in the baby.
Okay.
All right, this is a better phrase. And let's see what the examiner key says. Communication with the patient and the relatives, you're calm, you're composed, but just the problem is time management. So be a little quicker. Friends, the problem in exam was that this patient was adamant that my home records were fine. I was not giving much tougher time to Dalia because I knew that it would be a longer station already. How would you justify this thing? Anyone, an open question to everyone. How would you justify that our home records are fine and the lab records are not matching with the home records? In exam, this was the situation.
Yeah, we can talk to the patient that there might be a monitoring monitor had some defect, or there might be a storage problem with the insulin, whatever she's on, and there might be something in the like, you know. So we have to
agree. What happened in exam was that whosoever was sensitive to the patient asking about her in detail, she agreed that it was all fake. She wanted to get pregnant, so she wrote all the fake records in exam. So what I would say is that, Rebecca, we see many patients and they have difficulties in taking multiple times their blood and then making a record of these investigations of the blood record. So do you feel the same? And immediately she was like, yeah, doctor, actually it's so difficult to prick every time and take your blood and then write it down and take a note of that. So I just
do it quickly for 2-3 days myself. So that was only to those patients who made her, or those students who made this patient comfortable. Okay, only for those students who made this patient comfortable. So whenever you're going to ask directly, it would be very difficult that she agrees to this thing. But whenever you make her comfortable, like it's not only her. So many patients, they tell us that it's very difficult to maintain the home records. Do you feel the same? So she would be like, okay, I'm not alone. So everybody's doing that. So in exam, this was one example which I want to give you, because she was adamant that my glucometer is fine as well. My insulin dose is fine as well. How can you say that my reports are not fine? So probably it's a laboratory error. So then you make her comfortable. Did you all understand that how you're going to talk to if you come to this point in exam? If she tells you that everything is fine, my home records are fine, so you can simply ask her in a very empathetic tone, making her comfortable, that Rebecca, I see many patients who have difficulty in maintaining their home records. Do you feel the same, taking blood investigations every time and writing it down? So then she utters up this thing that, yes, doctor, it's very tough. I just wrote it down myself. So to few of the students, she did tell this thing. So that actually makes a very good impression to the examiner that you are such a comfortable doctor that she has spoken her heart out, that, you know, something which she knew only, she has spoken that, if she's adamant on that. Otherwise, the first thing always is that glucometer might have a problem, insulin might not be working, the dose might be inadequate, and at the same time, there can be a problem with the laboratory results as well. So all these possibilities are there for which you can repeat. So please tell me that if a diabetic patient, she comes to you in the preconceptional clinic, what is the cutoff when you have to repeat her renal and retinal assessment? Like I said to Dalia that I had it 6.5 months back. Yes.
If it is done in the last 6 months, then it's okay. But if it is done beyond 6 months, then we have to repeat it.
Okay. So if I say that now it's not a preconceptional case, Harshiba, Archana, it's not a preconceptional case, Dr. Bindu, and she's in pregnancy.
3 months, ma'am.
Every trimester, ma'am.
3rd trimester, sweetheart.
No, it's in 3 months, ma'am, if it's pregnancy.
Exactly. Very
Every
good.
trimester.
Very good. So what you're going to say is that if it's not in the last 3 months, then you'll do it booking. Right? Then you'll do it booking. So remember 3 months and 6 months cutoff according to the preconceptional and pregnancy time. Very good, Dalia. I was very happy when you offered me the kidney and the eye checkup. Very good. You took the history otherwise, other than the time management, my dear, your points were complete. I'm happy at least now we are at this phase that history is not missing. That is very good. But now when we have mugged up our history points, now we will work on time. Yes, Dalia? Yeah? So at least the first step is done, that now we have memorized the history. So now we'll work on second point, my dear, that we'll work on the speed. Okay?
Okay.
It was a mutually agreed plan. I was understanding that, yes, at this time, it is improper for me to get pregnant. How would I go with this station? Rebecca, after taking information gathering, right? So Rebecca, coming to the care with this condition and the pregnancy, I would like to tell you what it means to women who have this condition. There can be early pregnancy loss for these women. Along with that, there is increased chance of having clots in the legs and the lungs. Patients, they can have proteins in the urine and raised blood pressure as well. There can be a risk of having early birth than the due date. The labor can be prolonged in these women, and the chances of cesarean section is also on a rise. They can also have anesthesia complications. Even after cesarean section, Rebecca, the chances of wound infection is also more. And women with this condition can bleed a little more as compared to other patients. For the baby, the early pregnancy loss is one of the complications which we anticipate. Along with that, there can be some developmental problem in the brain and the backbone. We call it as spinal cord. The baby can be larger in size, can also be smaller in size as compared to the duration of the pregnancy. Rebecca, because of being larger in size, we can anticipate the birth injury complications. At times, the shoulder gets stuck and there can be some nerve injuries. The baby might die inside the womb or after the birth in the first few days as well. after the birth of the baby, there can be some fluctuations, some up and down in the minerals in the blood of the baby as well. Now, I will take you to the pregnancy journey and tell you, Rebecca, that how we are going to take care of this condition to decrease the chances of complications to occur. Rebecca, it's going to be a team of doctors taking care of you, my consultant, the specialized midwife, the diabetic doctor, and a specialized nurse dealing with this condition. Your diabetic doctor will adjust your insulin during the pregnancy, and you will have your kidney and eye checkup if not done in 3 months prior to getting pregnant. We will begin the baby aspirin 75 milligrams from the starting of your pregnancy from 12 weeks. You will have an ultrasound to date your pregnancy, then to see in the mid-pregnancy that the baby is formed normally, and from 28 weeks to see that the baby is growing normally. We will start your blood thinners from 28 weeks if at all the kidney functions are affected. Otherwise, we'll assess you if they are required. Am I clear, Rebecca? When it comes to the birth plan, it is going to be a consultant-led unit. Around 37 to 38 plus 6 weeks, we plan the birth. We would definitely aim for the vaginal birth, Rebecca, and the baby would be continuously monitored for the heartbeat. This birth would be accompanied by the baby doctor. During the labor time, we would maintain your blood sugar levels with the help of a sugar drip and an insulin drip. And every hour, the blood sugar will be monitored in labor. If at all we have to plan for a cesarean section, it would be 30 minutes under anesthesia. Am I clear so far? Once the baby is born, we will encourage you to breastfeed early, and we will discuss the suitable contraception for you, Rebecca, avoiding the combined pills. We will adjust the insulin dose again after the birth of the baby. We'll assess you for the blood thinners again and offer all the support which is required at that point in time. Let's come back to today. So, Rebecca, we are going to manage you now as a team of doctors. Rebecca, it is suggested that at this point in time, before getting pregnant, to avoid all the complications which I've told you earlier, the wake-up plasma glucose has to be between 5 to 7. And the plasma glucose that we say before other meals, that has to be 4 to 7. So we have to maintain these blood sugar levels, therefore, to avoid these complications to occur. From this point, monthly, we will do the same blood test which was deranged, and as soon as we receive less than 6.5 result, we will allow you to get pregnant. As 6 months have passed for your kidney and eye checkup, I would suggest that you have your kidney and eye checkup now. I'm going to connect you to your diabetic doctor today so that he can adjust the insulin doses, and after 1 month, we'll repeat your test to see how far we have achieved a good control. Would like to give you some general advice like avoid smoking, having a healthy lifestyle, maintaining a 30 minutes walk, and ensure that your rubella vaccination is done as well. Am I clear? Do you have any questions for me? I'm going to provide you with the patient information leaflet and connect you to the support group. Thank you very much for speaking to me, Rebecca. Hello, hello. Yeah? So this is how you people go with the type 1 diabetes. If it goes from the effects, the antenatal care, interpartum care, postpartum care, and coming back to the preconceptional care, it does not take time. Believe me, it takes like maybe 2 minutes, 2.5 minutes, checking, understanding somewhere in between, but at the same time, it would be just coming in flow if you have memorized these points. All these points were almost touched by Dalia. I appreciate that, but the sequence was a little up and down. Definitely would come with practice. Definitely would come with practice. Shaheen, you can say that baby heart would also be checked. Specialized heart scan would also be done. Okay? Archana, it would be perfect with practice. You're already going towards the perfect phase, my dear. You're already going towards that phase. So nothing to worry. Okay? Shaheen, you can say the specialized heart scan would be done for the baby, right? If you want to add on into the anomaly scan. Okay,
because I'm confused a little bit regarding to that, how do we address that risk assessment for venous thromboembolism to be done at the time of booking, then in labor, and then post delivery? So like only mentioning it at the postpartum care would be enough. Like it's in the ANC, na? The guideline that we have to assess the patient for VT 3 times. So we'll utter it in a one word, one line.
You say that we'll assess you for the blood thinner requirement. If she is having nephropathy in exam, then you'll definitely give blood thinners. Otherwise, you'll just score 1. You'll say that we are going to assess you for the blood thinner requirement during the pregnancy and after birth as well. So that's why I placed it twice, like once in antenatal care and second time in the postpartum care.
Okay, so once we utter, we will utter it in the last line, right?
Once in the antenatal care and then in the postpartum care. Twice. Okay, twice you're going to say that. Once in the antenatal care, assess you for the blood thinners requirement, and then in the postpartum care, we'll assess you for the blood thinners if at all they're required. All right, 2 times.
Thank you.
Okay, thank you very much. Thank you. So this is how it goes, Dalia. All the points, almost all the points like MDT, insulin adjustment, renal retinal, but I want a little more organized performance, my dear, okay? And definitely it would come with practice. It would definitely come with practice. All these things would be here, right? And Archana, you're already improved a lot just because of practice. The only key is practicing again and again. Open this up in front of you and try practicing. Try speaking it up and just time yourself. When you time yourself, things will be perfect. All right, got it? How the pregnancy diabetes would be. Now, diabetes is the one station which definitely comes in exam in 4 to 5 days of exam. 1 day is always diabetes, remember. So if you see the station, if you just cut it down, the preconceptional part here, this part would become your antenatal care. Clear? Harshaba, got it? This part, Dr. Bindu, this part will become your antenatal care. Right? So just remember the same template you can use for yourself. Where is Divya today? Divya, you're silent today. Why? Because you're not in the live session. Harshaba, where's Divya?
I think she hasn't joined today.
Okay.
Must be busy. Yeah.
Okay, we'll talk to her. Okay. So this is how it goes. Introduction, information gathering. Yes, Dalia. Hi, dear. Dalia, can you see here?
Yes. Yes,
I just want, sweetheart, your preconception was here. Right? I want that antenatal, intrapartum, postpartum, and then preconception here, my dear. So that in one go it gets completed.
Okay.
Okay? Very good. Well done.
Yes.
So keep it up, my dear. I'm sure next performance would be better. And we'll just work on timings now so that we speed up. So I'll give you a suggestion. Speak as fast as you can. That would be the normal speed. Because otherwise you're a calm or a composed or a slow speaker, right? So for my fast speakers, I say speak as slow as you can, so that you know that is the normal speed. Okay. So for you, I would say speak as fast as you can. So then you would definitely be at the normal level. All right. Very good. Well done. Thank you very much, my dear. Keep it up. Keep it up. Okay. So let's do 6th station. Hello, Harshaba.
Hi, ma'am.
How are you?
I'm good. How are you?
Thank you very much. I'm very well. So let's start the 2 minutes because you already have done perfect stations up till now. So from my side, the most difficult station of the day I've kept for you and Dr. Athiya. So let's begin. Go ahead.
Yes, ma'am. Hello, I am Dr. Harshada. I'm one of the doctors in the antenatal clinic today. May I confirm your name and age, please?
Yes, hi, doctor. Doctor, I'm Monica Simons. I'm 29 years.
Hi, Monica. Is it okay if I call you Monica?
That's okay.
Okay, so I gathered from your notes here today that you are currently pregnant and you are suffering with a condition known as Charcot-Marie-Tooth. Am I right?
Yeah, exactly, doctor.
Okay, so Monica, in the next few minutes, we will discuss all your concerns and I'm going to come up with a safe management plan for you in discussion with you. But before that, is it okay if I ask you a few questions to know more about you?
That's all right.
Okay, so Monica, can you tell me more about this condition that you're having?
Yeah, doctor, it's been around 6 to 7 years now that I was diagnosed with Charcot-Marie-Tooth disease. Actually, initially I had some problem with my movement and mobility as well. I had a surgery for my foot. It was flat foot, and I could not walk properly with that. But now it's better after the surgery. Yes, I can do walk now. I don't have any problem at the moment. I have been undergoing lots of physiotherapy as well. At the moment, I'm not taking any medication for this, and I'm all right. The only problem is that I'm not able to exercise well. So because of some static life, I have my raised BMI as well. Otherwise, I'm all right. Yeah.
Yes, I appreciate you've been through a lot, Monica, but don't worry, we as a team of doctors here will help and support you throughout this pregnancy. So Monica, as you said that besides mobility issues, there are no other problems like any problems with breathing or eating?
No, that's fine.
Okay. So Monica, can you tell me if you have ever visited a specialist genetic counselor for this disease?
Yeah, I have visited the genetic counselor. In this pregnancy, they offered me needle test as well, but I was not convinced with that because they told me that it can cause some pregnancy loss as well. I'm very happy with the pregnancy doctor. I don't want to have a pregnancy loss. So I refused them for me to undergo some screening.
Okay, I appreciate your concerns. So is this your first pregnancy, Monica?
Yeah, this is.
And is it a planned pregnancy?
It is, yeah.
Okay, congratulations on your pregnancy. So I understand that you're 12 weeks into your pregnancy, right?
Yeah.
Your periods have been regular before this?
Yeah.
Okay. Have you visited a midwife so far?
Yeah. She did some booking test and some ultrasound. Everything was fine up till now.
Okay. Have you been started on folic acid so far?
Yeah, I'm taking that.
And may I know what dose you're taking it in?
Yeah, that is high dose 5 milligram.
Okay, that's good to know. How has your pregnancy been going so far? Any problems you are facing?
No.
Walking? Okay.
No.
Okay. May I know what your blood group is?
A positive.
Okay. Any other medical conditions that you're aware of, Monica, besides this?
No.
Okay. Any surgeries besides those performed on your feet? Any other on your tummy or down below?
That's it.
Okay. How about any diseases running in your family? Do you have any similar problems in your family?
Not exactly. I'm not aware of actually.
Yeah, it's okay. Okay, so any other medications that you've been on? Any painkillers?
Not at the moment.
Okay, any drug allergies?
No.
I see. Monica, do you smoke or drink, or pardon me to ask, use any recreational drugs?
No, doctor. In pregnancy, I'm not doing anything. I'm not taking anything.
That's good to know. So how are things at home and what do you do for a living, Monica?
Yeah, I just stay at home actually. So yeah, I don't do anything.
Okay, no problem. So in the past few weeks, how have you been feeling? Any episodes of sadness or tearfulness?
I'm fine otherwise because now I'm in a better condition and I'm happy with the pregnancy as well. So that makes me cheerful.
That's good. Thank you for all this information. Is there anything that you would like to add to it?
Yeah, that's it. That's it. Yeah.
Okay. So, Monica, I see that you are having this condition. May I know what all you already know about this with regard to your pregnancy so I can elaborate on the other things?
Yeah, what I know is that this is something which affects my nerves, and for that reason, my muscles they are weaker.
Okay.
Yeah.
Right. And another issue, Monica, is your weight to height ratio that will cause some problems to both you and your baby. So is it okay if I discuss with you what problems there can be in this pregnancy to you and your baby?
Yeah, okay.
Okay, so in this condition, Monica, actually, it sort of becomes worse in pregnancy, especially, with your weight. So you need to keep moving around, and you need to not try to be in the same position always. You need to avoid, falls, because that can lead to further problems. Because of the fact that your height to weight ratio is high, we will have to put you on a few injections that will reduce the risk of clots forming in your legs and lungs. We will be assessing you throughout the pregnancy for the need of these injections, and we will also continue it after your delivery for 6 weeks. Coming to your baby, Monica, as you know that this condition is an inheritable condition. That means it can be passed down in generations. So there is a slight risk that your baby can have this problem. Am I clear?
Okay.
Okay. As far as your journey through your pregnancy is concerned, Monica, we will be taking care of you as a team of doctors. There will be a specialist bone doctor, doctor that takes care of nerves, a neurologist, a high-risk obstetrician. There will be a physiotherapy doctor, an occupational therapy doctor, and also a dietitian who will be advising you regarding your diet and exercise regimes, so that your weight gain is under control during this pregnancy. We will be giving you a certain diet that also helps you to lose a healthy amount of weight as your BMI is quite high. Okay.
Okay.
So Monica, as I told you, this disease can be transferred to your baby. May I know what are the concerns that you have regarding not getting the needle test that was already advised you?
I just don't want the pregnancy loss. That's it.
Okay, so I would like to tell you that in your condition, without testing you and doing a needle test for your baby, we cannot be sure of whether your baby will be affected or not. And as I can see that you have been through a lot during your years of this disease, and you've been a strong woman and you've been a savior. And I am not sure if you would want your baby to go through the same. So maybe you could consider this test, because the miscarriage rate is just 1 in 100 women.
It's okay. I'll think about that. What about my delivery, doctor?
Yes. So as I said, you'll be under close observation. We will start you on, we have already started you on folic acid. We will also start you on aspirin as your weight is high and this is your first pregnancy. We will do a down screening test on your baby, and also a mid-pregnancy test to check whether the development of the baby is fine or not. We will be doing a sugar test, which is called glucose tolerance test at 24 to 28 weeks, just to make sure that your sugars are fine. At 36 weeks, Monica, we will hold a joint meeting with all the doctors who are taking care of you to decide the time and the route of your delivery. You will be meeting an anesthesia doctor also, who will take care of your pain needs during delivery. And we will also be starting you on injections for reducing clots in your legs and lungs. Your delivery is going to be under a consultant-led unit, and we will be closely and continuously monitoring your baby's heart as well as your progress. If there is a need, mostly we will aim at a vaginal delivery, but in certain cases like yours, where there can be problems with your hips, your positioning, and because of your weight, there is a slight concern of proceeding with a cesarean delivery if the progress of your labor is slow. And we would be taking care of the, in certain cases, there is excessive bleeding at the end of delivery, so we'll be handling your delivery with appropriate drugs and fluids with a competent team of doctors. Monica, after your baby is born, baby will be checked by the baby doctor, and you will be advised to hydrate yourself well, move around to prevent any sorts of clots, and your injections are going to be continued till 6 weeks after your delivery. You will be encouraged to breastfeed your baby, and we will discuss a safe and effective contraception plan for you. We will try to avoid anything that contains estrogen, because that increases the chance of clots in your legs. Coming to today, I will schedule an appointment with my consultant for you, as well as a dietitian, and I'm going to start you on aspirin, which is 75 milligrams, and I will see you after 2 weeks, and we will do a down screening meanwhile for you. An ultrasound. Also, I would like to give you a few information leaflets which have information about this disease, and also about the needle test, which you can be considering after going back home and discussing with your family. I'll connect you to some support groups as well. Okay.
Thank you very much, doctor. Thank you.
Okay. Thank you. Thank you for your time.
How was it, Harshaba? How did it go? A combination of chocolate with obesity, yeah?
I missed a few points, I think, in obesity.
Chocolate Mary specifically. You concentrated more on the BMI. The Chocolate Mary points were missing in the station somehow.
Yeah. I forgot the prolonged labor and malpresentations.
Exactly. You also when you came to the effects, you said that, can I discuss with you the effects that can be on you or the baby? And immediately I said, yes, doctor. And immediately you came to the management of antenatal care. So what we'll do is we'll give you blood thinners. What we'll do is that we'll tell this. So I was waiting for the effects. Yeah? Yes, Jyoti. She would have 150 milligram.
Yeah.
Yes, 150 milligram because of the obesity guideline, 100%.
I didn't remember obesity.
No problem. So because your threshold already is very higher in front of me, so the appreciation comes according to the background, Very well done regarding the station. Introduction was all right. Agenda making was good. Information gathering regarding CMT was not there. What are the specific questions which we need to ask about the Charcot Marie Tooth disease, please, to see that how far Charcot Marie disease? Because in the station, did you people understand that how is my life with Charcot Marie Tooth disease? Did anybody analyze that?
Yeah, we need to ask how much mobile she is, whether she said she's able to do most of the things. She's able to go.
So what does that mean? Jyoti, most of the things might be different than your routine. Yours might be different from somebody else. Yeah?
To ask exactly what she can do and cannot do, and how is she able to, also we need to ask how much support she has, and is she planning for any extra support when during her childbirth.
So let me tell you guys that in CMT, see her history taking regarding the pregnancy 12 weeks was fine. Regarding CMT, we need to ask few things, and which are specifically in Charcot Marie Tooth disease group, they give that what are those things which make us know. They have problem with the nerves, right? So they have the problem with their movements and that complicated, intricate movements of the fingers and of their coordination as well. So I would like to know, Monica, do you ever feel tingling sensation, numbness, pins and needles? Can you walk with ease? Have you ever tried swimming? Can you perform combing, button and unbutton of shirts? That's it. These lines you have to cram up, because these are those small things that which this Charcot Marie Tooth disease, this tells us that how far she has a restricted lifestyle. Am I clear? Walk with ease. Sarvat, how do we ask that? Can you walk with ease? So help and mobility the other way around. Got it? So I would repeat that again. For sensations and for movements, two things you all need to ask. Everybody please notice down. Dr. Atia, are you done with dinner? To maintain your glucose level. Get connected here. Sarvat, Dr. Sabia, please note down. Everyone, I need an attention. Dalia, Nadra. Okay, so you need to ask that did you ever experience tingling, numbness, pins and needles? Can you walk with ease? Have you ever tried swimming, combing? Can you button and unbutton easily? Simple. So these are those things which would make you, and if she says yes, you're 100% like comfortable that this is an easy patient. Otherwise, in the entire station, I was waiting in the MDT to have the nerve doctor input as well, Harshiba. Even in the end, you didn't connect her to the nerve doctor. Neither you asked in the history. So when was your last visit to your doctor? Am I right?
Yes, ma'am.
Yeah, even in the end, I've written down, what did you say? You said that I'm going to connect you to the dietitian for the physical exercise. I'm going to connect you, all these things you mentioned, but I was waiting that please get input from the nerve doctor as well. So that is very important.
Actually, I got jumbled between obesity and
Exactly.
CFT.
And that's why I kept this station for you, because Chaukat Mary had increased BMI in exam as well. But the best part in exam was exactly Dr. Sabia. But the exam best part was that it was a Chaukat Mary 2 disease without any disability at all. Even then, when you but how would you come to know? You would come to know about this when you ask these questions. So these questions were missing. After that, all your questions about the folic acid, blood group, medical, surgical, family history, everything was fine. But CMT questions you have to add on, okay? Now everybody has to add on these questions which I've spoken of. These are the tiny questions which tells you about the intensity of CMT. Then effects on the mother and the baby, they were missing as well. I could not get the CMT. Go to the recording, Harshiba, again. The effects on the mother and the baby, you seek my permission that can I discuss with you? I said yes. But then actually we went to the management. You started managing this condition. So again, this was, you said that keep moving around, avoid falls. So this was the management. This was not the effect, right? So effect you have to tell first, and then you have to come to the management. The best part was it did start aspirin, you did do OGTT, that was all good, and MDT has to be spoken in the start. In exam, there was one leaflet of CMT was given because it was an alien term. Of course, before this, I think we never knew what Chaukat Mary tooth is, and we never knew that this is something which is existing in this world. Because
Yeah,
it's so
ma'am, I
rare.
didn't know.
Yeah. So just imagine the condition of those students who had this for the first time in exam. They would be like, what in the world is this station about? So just follow the maternal medicine template, right? So coming to the communication, your communication is always good, very good, 2 by 2 in communication. History template, I will give you 1 out of 2 borderline today, just because of not asking the level of the effect of Chaukat Mary into her life, quality of life. Patient safety, VT prophylaxis was there. You were not open about the complications. I wanted these, so 1.5 in patient safety. Applied clinical knowledge about the Chaukat Mary tooth disease. If she knows the background, once you said that you checked my background, I was very happy. If she says that, doctor, please tell me, you simply have to say that, Monica, this is a condition that affects the nerves that run from your brain and backbone to the limbs. It runs in the families, therefore the muscle control is affected as it contains a fault in the gene. Let me tell you what it means to the patient. Around 1/3 of the women, they get worsening of this condition in pregnancy in terms of increased muscle weakness, numbness. It may affect the way of walking as well. At times, it's difficulty in walking and they require support. The chances of having difficult, prolonged labor is more. Having instrument birth chances is on a rise for these patients, and also cesarean section chance is also more after the birth. The bleeding risk is also higher for these women, and the chances of having blood clot formation is on a rise for these patients. The baby can get the same condition from the mothers and can be born early than the due date and can have the complicated features because of early birth. About your plan of birth and your pregnancy journey, it's going to be a team of doctors, my consultant, the physiotherapy, the dietitian, the exercise specialist. Along with that, your regular review with a nerve doctor is essential during the pregnancy. I would suggest that you take 5 milligram, that is higher dose of folic acid. We would suggest a genetic counselor so that he can tell you and talk to you about the chances of baby having this condition, and will suggest the needle test if at all you agree to that. At every visit, the blood pressure test and the urine test would be done. We'll provide you with a suitable exercise program regarding your BMI, and the blood thinners you will be assessed about if they are required, and we'll give you the suitable dietary advice as well. The birth plan would be decided around 36 weeks of your pregnancy, Monica, and it's going to be a consultant-led care. We will aim for the vaginal birth, and it is going to be one-to-one care during your labor time period, and the baby heartbeat would be monitored continuously. We will give you adequate pain relief, and the anesthesia doctor will talk to you if cesarean section is required about the suitable anesthesia which suits you best at that point in time. Once the baby is born, we will give you specialized medications to prevent the bleeding after the birth of the baby. We'll encourage the breastfeeding. We'll assess you for the blood thinners. Physiotherapy would be continued at this time period. We'll suggest you the diet and the weight loss advice at this point. The baby would be tested by a heel prick test. The baby doctor will talk to you at that time, and we'll suggest you the suitable contraception at that point in time. Please keep checking the understanding in between. I'm going to give you the patient information leaflet regarding the same and connect you to the support group, the chocolatemarytooth.uk, so you can talk to other women who have the same condition, so you have a better understanding of your condition and how the pregnancy would go. Any questions for me, Monica? Now, this is about the Charcot Marie Tooth. If it's obesity, you will add my antenatal care template of obesity, and you will add on 2 things here. Here you will add on the obesity risk factors as well, and here you will add on the aspirin and the OGTT because of obesity. This is sold for the Charcot Marie Tooth. When it is a combination, you just have to add. So there the station becomes a trouble. Don't forget, in exam Charcot Marie, they won't give you a complicated Charcot Marie because itself it's something which is many of the students, they don't know what it is actually. So if you're knowing that what Charcot Marie is, are you people aware of different types of Charcot Marie tooth disease? How many types do we have of CMT?
6 types, I think. 6, 7,
Yeah,
7.
what are they? There are 5 types. Very good, Dr. Bindu. Whenever it comes to applied clinical knowledge, we've got an encyclopedia here. Dr. Bindu, what are the 5 types? CMT1, that's autosomal dominant, friends. CMT2, that's autosomal dominant. Then we've got CMT3, which is severe form, starts from childhood, it's autosomal dominant. We've got CMTX, that is X-linked. Then we've got CMTH, that is autosomal recessive. Very good. So these are the 5 types of Charcot Marie tooth disease. Because the inheritance pattern is different, so you can ask in the history, may I know what type of Charcot Marie tooth disease do you have? Or you can simply say, may I know the detail about your condition? So let her come up with what type she's having, okay? Dr. Bindu says that, can we ask how far is disease affecting your routine activities? Now, actually, again, Dr. Bindu, routine activities, how does she get that thing? Again, I would say my routine activities might be different from yours. Yours might be different from Atiya's. Atiya's might be different from Dr. Sabiya's. So routine activities is not something like, a question which might be interpreted. So tiny things like combing, button, unbutton, these are the things which have like no ambiguity in the question. So it takes like 5 seconds. So it's better to be precise. Okay. One thing you can ask is how far it is affecting your quality of life. So then she would be like Claire. So again, I would like to emphasize the Charcot Marie tooth in exam was an uncomplicated in which her quality of life was not getting affected, but it was a combination that she had a raised BMI as well. So there are things they went wrong. Am I clear about the situation now? Right?
Dr. I would like to ask, just for my knowledge, I would like to know, can this patient take a regional anesthesia or it's not, it's contraindicated?
It depends upon type of Charcot Marie and how far the lungs are affected or the breathing is affected.
Okay.
So if it's not affected, all types of anesthesia are safe. That's why we are saying that at that time, the doctor would talk to you.
The doctor, okay.
Yeah, because if the lungs are getting affected and the respiratory muscles are getting affected, so definitely then the choice would be no, the general anesthesia. So this actually depends at that point. So the safest way is anesthesia doctor will talk to you.
Okay.
Okay. All right, no problem. No problem, Harshipa. I gave this station because I think that this is the most difficult station, and yes, one more difficult station out of this maternal medicine today. So I kept my top 2 students for that. If anybody else would have been doing the station, I'm sure this would have been difficult for them as well. So you did almost very good. 2 of the domains went borderline, but your communication is always good. So very good, my dear. I kept this station for you because you're already Your standard and your bar in front of me is way too higher. Keep it up, my dear, and stay ready for multiple difficult stations in future as well. Well done, my dear. Well done. So this is how it goes, friends. About introduction, agenda, information gathering, a combination of obesity and Charcot-Marie mother and baby effect, antenatal, interpartum care, postpartum care, address the concerns, follow up plan, patient information leaflet, and yes, the support group. And let us move to the second last station of the day. No problem, Haishaba. No weeping, my dear. Communication with the patient is passing. Information gathering. Why borderline? Because CMT questions. And anybody who is in the session today won't be knowing these questions which I've told. Am I right? Anybody knew these questions about the CMT, that how you have to assess the CMT level? Anybody knew about these questions? No, right? It's an information for everybody, right? And about
Ma'am, I'm crying because I forgot obesity also.
Okay, no problem. No problem, Harshaba. Give me a smile so that we can continue further, or else with tears we cannot continue. You know me. Yeah, no problem. We'll see. Making mistakes today is understandable. It's acceptable. Making mistakes in exam is not acceptable. That's perfect. That's like my girl with a huge grin on the face. That's like my girl. Well done. Okay, so let's start with the station number 7. And whom do we have? We've got Abir here. Hello, Abir.
Hello, doctor.
Hi, my dear. How are you doing?
Alhamdulillah.
That's wonderful to know. May you always stay fine, sweetheart. So let's start with the station. What are you getting now, Abir? Dr. Sabia, what am I giving to Abir?
I don't know. Pulmonary hypertension.
Pulmonary hypertension.
Pulmonary hypertension.
Van Willebrand.
Van Willebrand.
Abir, you tell me, what does your heart say? Lubdub, lubdub,
yes.
What is the heart rate at the moment?
Already I am a bradycardia, so maybe
don't tell me bradycardia, it should be tachycardia.
No, I am 80-85 because my normal range 60.
Okay, but I'm very happy, Abir. You and Dr. Sabia, you are two people who are very early in the station, and you keep on reading the things together until late night. You people are, studying together. So I'm very happy, my dear, for the hard work, and I'm sure you will do great. Okay, let's begin with a 2 minutes time, and let's see what do we have for her.
Next. Okay. Hello, I'm Dr. Abir. I'm one of the doctors in the clinic today. May I confirm your name and age, please?
Hi, Doctor. I'm Mrs. Zari Breyer. I'm 25 years.
How can I call you?
Yeah, Zari is okay.
Okay. Zari, what I know, you are, from your notes, you are a case of von Willebrand disease type 3, and you are today for booking. I am correct?
Yeah, exactly, doctor. I'm at 12 weeks of my pregnancy.
Okay. Before we go to discuss your condition and booking your visit, may I ask you a few questions to know more about your condition?
Sure.
First of all, tell me more about your condition. When you start to diagnose, you take any medication? How are you coping with this condition?
Yeah. So when I started my periods, doctor, they were a little heavy, around 12 or 11 years of my age. So
Yes.
then they diagnosed me with this condition that I have type 3 von Willebrand disease. Generally, I never had a problem. It is only in periods that I have heavy periods, and they give me tranexamic acid during the periods. I take that for those 7 days, and then I'm okay. So I manage it well. Other than that, 5 years back, I had a fall. Because of that, I had a little more bleeding. So they gave me desmopressin during that, and I responded well to that. My levels were all right. It was 5 years back. Other than that, I never had a blood transfusion, never I had desmopressin. Things are going fine. As soon as my first day of period starts, I start taking tranexamic acid. That's it. So now, because I'm pregnant, I'm just worried that my baby would be okay. Other than that, everything is going fine, doctor.
So you followed your doctor?
Yeah.
Can I know last visit when?
Yeah, I met my blood doctor just in my first few weeks. Midwife referred me to him, and I went to him. I was 7 weeks pregnant at that time.
Okay. And you start your folic acid?
Yeah, I'm taking that.
Great. Yes. Okay. Now, tell me, have you ever been pregnant before?
No, this is my first pregnancy, doctor.
And it's a planned pregnancy?
Oh, yes, yeah.
Oh, congratulations.
Thank you.
Any medical condition other than von Willebrand?
Other than this, no.
Okay. Any surgery in your tummy or from down below in your womb?
No.
Okay. Are you drink alcohol?
No.
Smoking?
No.
Any recreational drugs?
No.
Are you aware about your height-weight ratio?
23.
Okay. And what do you do for a living?
Yeah, I work as a teacher.
Okay. With whom you live?
I live with a partner.
And he's supportive to you?
Yeah.
Okay. How things is going in the home?
That's perfect.
Okay. You have any drug history or drug allergy?
No.
Are you aware about your blood group?
A positive.
Okay. And I want to ask you if there is any family history of concern, any one in the member of your family carry the same disease you have?
I'm not aware of, doctor.
Okay. No other inheritable condition in your family?
I'm not aware of.
Okay. Any clots in the legs, in the lungs?
Not aware of.
Okay. I want to ask you about your partner. You have any idea if he is about her condition, if he is a carrier for von Willebrand disease or no?
Doctor, he has no symptoms as such like that of mine, so he has never been tested. If you say so, I can make him undergo the investigation, yeah?
Yes, that is very important to be test your partner because it affects the chance of your baby. Okay, thank you for sharing this information with me. Now, in the presence of chaperone, after your permission, I want to examine you. I want to examine your blood pressure, pulse rate, temperature, respiratory rate. I want to examine your tummy. I want to check also your height-weight ratio. So how does this sound for you?
Yeah, that's okay, yeah.
Okay, thank you. Now, I want to ask you, do you have any knowledge about von Willebrand disease?
Yeah, yeah, I know about this, that there's some sort of a factor which is less and that actually causes blood thinning and the clotting is not done. I'm aware about this, but I'm not aware about how does it's going to affect my pregnancy. I'm not aware of this fact.
Okay, you know it is an inheritable disease due to lack of a protein that's helping stop the bleeding. Also, it is important to the other clotting factor in your body. Since it's inheritable, I want to tell you this is a pregnancy we suggest is a high risk pregnancy. So your care through pregnancy should be by a group of specialists. We called it multidisciplinary team. It is composed of consultant, obstetrician, blood doctor, anesthetist, baby doctor, specialist midwife, specialist nurse, also genetic doctor. Genetic doctor actually he will tell us the chance of your baby to carrying this disease after assess your condition and assess the according to your partner condition. And actually during a pregnancy, this is done through what we call needle test. If you, it is a thin needle after numbing of your tummy skin, we pass it through your tummy to take a small part of your afterbirth or fluid around your baby. This is according to the what the age of a pregnancy this will be done. What we taken through needle test, it will be checked in the laboratory to see what are the genetic status of your baby. Actually, for any procedure, there is pros and cons. Actually, it is a definitive test tell us about your baby, but it's carry 1 to 2 in 100 risk of miscarriage.
Okay.
Okay.
So what can be the effects on my baby and me for the pregnancy?
Okay, the effect of this disease for you and your baby during a pregnancy. Actually, it is very important during booking to checking your to check the level of the vulnerable brand factor in your body. During a pregnancy, we have, according to, if you don't know, we have 3 types of von Willebrand disease. The first 2 types, it may be, the first type, it will be become improved during pregnancy because there is increase in the level of the von Willebrand. But type 3, you know, there is a severe lack in the von Willebrand. So you may expose if there is any miscarriage done, you may expose a bleeding more than the bleeding that's occurred to the women in the same gestational age. According to your baby, it is the effect. It will be according to the condition of your baby. If he's which type he's carrying. So during antenatal care, we carried by a multidisciplinary team, as I say. All the routine investigation will done for you, such as booking test, screening for Down syndrome, a normal scan, but we check your level of the factor at the booking, and also we check it again within the last part of a pregnancy, because if we exposed to any surgery or exposed to any interference, you need Zari to check the level, because you may be exposed to a bleeding. In the last trimester, we check it also for you, because to be optimized by the blood doctor, if you need to give in a factor or need to give a medicine to increase the production of the von Willebrand factor in your body. It is called desmopressin. You hear about it or you receive it before?
Yeah, I told you once I had that.
Yes, yes. Okay, during intrapartum will be we are advised to be delivered in the consultant labor unit, and your fetus will be monitored during pregnancy. Actually, for you, we are not done for you interference, because you may be exposed to bleeding. Also, according to condition of your baby, we are not do the special monitoring for by scalp electrode or any instrumentation, because it may lead to effect your baby by either intracranial hematomas and a bleeding inside the head, or a scalp collection of the blood. After your delivery, actually the anesthetist will discuss with you the choices for analgesia, if it is spinal or dural, or if you need cesarean section. Cesarean or vaginal, actually, according to your condition and the genetic status of your baby. Postpartum, we check for you and assess your condition. We cover you by either a factor or a medicine that help to prevent dissolving of the clots. It's according also to your situation, but we are advised to still with this medicine until the lochia. This is the remnant that is that's precipitated from the uterus after delivery until it's end. Sometimes there is a severe condition, you may need to be keep on this medicine for more than 2 weeks. I'm clear so far till now for you?
Yeah, I'm clear about that, doctor. So when do I have to come next, and what do I have to do now?
Now I will refer you to a blood doctor. It will be check your factor and optimize your treatment if you need any treatment. Also, a genetic doctor will be counsel you. But I want to tell you, postpartum should be agreed to a plan for contraception to avoid any unwanted pregnancy. Breastfeeding will be, I will encourage you to breastfeed your baby, but baby doctor should be see your baby and assess from the cord of your baby, assess the level of the factor, and maybe give you definitive diagnosis of the genetic status of your baby, which type he's carry, and if it is severe or mild. Sometimes we need to do scan for the baby to exclude if there is any bleeding inside the head of the baby or else. You have any question?
No, that's okay. I understood, doctor. When do I have to come now?
Sorry?
When do I have to come now?
I'm sorry, I cannot get you.
When do I have to come again, doctor?
Yes, okay. Now you are at 12 weeks. We are give you a schedule for your antenatal care. We agree for it with you. There is a plan for you. And there is a patient information leaflet and supportive group link I want to give you. This is give you more information about your condition.
Thank you very much, doctor. Thank you.
Thank you.
Yes, Abir, how did it go? let me tell you.
I'm a little bit not organized.
Let me tell you. Till 5 minutes, it was a total pass station. The way you started, the way you made agenda, the way you started your information gathering. Abir, your information gathering has improved a lot. A lot has been, the flow, the sequence, the choice of words, one after the other, the history coming one after the other. That has improved a lot. After 5 minutes, the station went in the down scale, one after the other, one after the other.
Yes.
Still 5 minutes.
When you ask me what are the effects, I become lost. I don't know what happened.
When I asked for the effect, I wrote in the chat box as well. You completed your history. See, I make algorithm every time. Now it should be on your tips that after information gathering, you people have to tell effects on the mother and effects on the baby, right? Yes. It should be on your tips. Immediately after you finished your history, you started telling me about the group of doctors will take care of you. That would be after telling the anticipated complications, right?
Right, yes.
Now, effects on the mother and the baby were short again, like in previous station CMT as well, they were not there. In antenatal care, you came twice to that. After 5 minutes, station got a little, every passing line made it like goes down and down and down. In antenatal care, it was a little scattered information, my dear. I would like to be a little more organized, but I'm happy with your flow. Your communication has improved a lot. But being organized and structured you still need to work on that. And we will definitely do that. Nothing to worry, okay? There were 1, 2, 3, 4, 5, 6, 7 jargons used in the station. 7 jargons. What were they?
What are they?
Trimester, intrapartum, scalp electrodes, anesthetist, analgesia, general anesthesia, spinal anesthesia, epidural anesthesia, postpartum care. All these are the words which we don't have to speak. If you have to speak third trimester, and they were one after the other, in just 30 seconds, all these words, they came. Just go back to the recording, you'll realize. For the trimester, you have to say in the last part of the pregnancy. During the labor is intrapartum. Scalp electrode is, you said about the scalp sampling probably. You just have to say taking a sample from the scalp of the baby, right? If you have some concerns regarding the baby heartbeat, yeah? Then it's anesthesia doctor. Then pain relief is analgesia. And then after birth, the care would be in the postpartum. So all these words came in just 1 minute. And I didn't want to interrupt you at that time by saying that, what is that, doctor? Because the time was less, so I was taking care of that as well. But in the end, you referred me to the blood doctor. That was all right. Factor level checking, I was not sure about, which we have to do according to the guideline recommendation, my dear. I was very happy when you checked for the partner screening. That was good. If it's not tested, I said it's not tested. So in the recommendation, please do that now. You know, in the end, I would refer you to the genetic doctor so that the partner is tested and we come to know that how far the baby is at risk. All right. And otherwise, information gathering part was very good. Few points I would just like to add. Regarding the Von Willebrand, the type is already given. If not given, please do ask why. Why are we concerned about the type of Von Willebrand, friends?
Because it's affect the management.
And inheritance pattern as well, right?
Yes, yes.
Yeah. What is the inheritance pattern of type 1, 2, and 3? Guys, what is
autosomal dominant? Type 2 is autosomal dominant except type 2N, and type 3 is autosomal recessive.
Very good, Archana. Very good. Well done. Remember, 1 and 2 and always dominant because they are first and second, right? So 1 and 2 are dominant. 2 is, other than 2N, every type is dominant. 2N is recessive and type 3 is recessive. So she is autosomal recessive, same as that of sickle cell or thalassemia. Okay. Few questions which I would like to ask in the beginning is that type if it's not given. Otherwise, may I know that any complications occur? Do you bleed more from gums and cuts? Any sort of admission? And when I said that I responded to desmopressin, what I was trying to tell her that there are 2 types of Von Willebrand disease type 3, a responder and a non-responder. A responder responds to desmopressin and a non-responder does not respond to desmopressin. You have to give Von Willebrand factor to her. Okay, so this was the reason. Abir, your communication with the patient has improved, my dear. Now you talk in a comfortable manner. Initially, it was a little more difficult to talk to the patient, but this time it has improved a lot. So let's see the positive things which we have learned up till now. Okay, so communication with the patient has improved, and now avoiding jargons you have to do. Group A, who is here from Group A? Rama? Dr. Sabir?
I'm here from Group A.
Thank you very much. So your partner this was the
first station we practiced, and it was done by me first. And I was the one I teach these stations.
Okay, so work on whenever Abir uses jargon, stop her there and then. So intrapartum, postpartum, these words are not to be used. Check on her on this, right? During labor, after birth, inshallah. You have to work on this, that she doesn't use these terms because when you people work on each other, it becomes like part of your memory, right? Discussion plays a role. So this thing you have to work on her, and moreover the management plan, organized management plan, you have to work on each other. Otherwise her history has improved a lot. So a good clap for the information gathering for Abir. This is first step in a station which you have improved. Information gathering has really improved a lot. And that has coming one after the other. That was very good, Abir, for this station. Well done. Now, patient safety, MDT, was patient safety which you touched. The intramuscular injections, I wanted to hear that. Not taking scalp sample, avoiding the cup deliveries, and using the high forceps we have to avoid. You did say about the instrumentation somewhere in between. Giving medications to prevent bleeding and doing the baby head imaging prior to discharge, all these points for patient safety. Regarding the applied clinical knowledge, I will go with Zari, that Zari, the von Willebrand disease, this condition can affect the baby by having the same condition like that of the mother, and the baby has chances to have bleeding inside the head or outside as well. For mother, worsening of this condition can happen and the bleeding risk is there. During the pregnancy, it's going to be a team of doctors taking care of your condition. That would be my consultant, the blood doctor, and the specialized midwife. You will have frequent visits. Around 20 weeks, we'll have the scan to see that the baby is formed normally, and serial growth scans from 28 weeks of pregnancy. The most important thing is that we check these factor levels, Zari, during the pregnancy, which would be at your booking visit now. And in the third part of your pregnancy, if any needle test would be done prior to that, we will check the factor levels. If the labor goes longer, we will check the factor levels and after delivery as well. Zari, we ensure during the pregnancy that these factor levels are more than 0.5. If at all they fall below 0.5, a specialized medicine which you used once earlier, 5 years back as well, we will give that desmopressin, with which we will ensure that restriction of the fluid is done around 1 liter in 24 hours. Coming to your labor, it is going to be a consultant-led birth. We will aim for the vaginal birth, Zari, avoiding the injections in the muscle. If we have some concerns regarding the baby heartbeat, we will avoid taking sample from the scalp. Delivery can be done through instrument forceps, low forceps. However, applying forceps on a high head or a cup deliveries would be avoided. If the labor goes prolonged, we will have a low threshold for deciding for a cesarean section. Anesthesia doctor will talk to you about the right anesthesia suitable at that point in time. After birth of the baby, we will have to ensure that the factors are more than 0.5 for at least 3 days if it's a normal birth, and for 5 days we have to maintain that, Zari, if it's an instrumental birth or a cesarean section. The same medicine which you take for the periods, your cycle, that would be given to you for 7 to 14 days after the birth of the baby. The baby would be checked for these factor levels through the cord test. Instead of giving in the muscle, we will give vitamin K orally to the baby, and the head imaging will be done for the baby prior to discharge of the baby. Am I clear about the management plan? Do you have any questions from me, Zari? I will give you the patient information leaflet regarding the von Willebrand disease. We'll connect you to the support group as well. I will connect you and fix an appointment after 2 weeks to the blood doctor. We will check with the first factor levels and with my consultant as well. So see you in 2 weeks' time. Thank you. Am I clear? Yeah? This is how in a sequence, few things were missing, like this in the postpartum, greater than 0.5 for SVD and for 5 days for IVD and cesarean section, care of the baby, and here avoiding these things are your patient safety as well, my dear, and also these are the important points for the von Willebrand disease as well, okay? Partner is not screened up till now, so please remember, other than this, von Willebrand does not have any other effects. So, when after 2 weeks time, because she said that it's not the factor levels are not checked, so you have to ensure that they are more than 0.5, okay, in 2 weeks time, right? And that too with a consultant, because this is the missing appointment. All right, any questions regarding von Willebrand disease, please?
You know why I am lost in the, because because I have no question for effect on the mother on the baby.
Yeah. Now you see, Abir, now you see that how much less it is. Only the chance of a bleeding, that's it. No growth restriction, no perinatal mortality, morbidity.
Prepare themselves our preterm labor, IUGR.
I understand. So it was not there. I understand. So this was otherwise the quickest part because less effects were there. Yes, Shaheen, you have raised your hand, please. I'm open to the questions, my dear. Yes, Shaheen.
Yeah, I just want to ask, in this scenario, there is no growth restriction. So, is it necessary to do serial growth scans, or it is for all high-risk pregnancy?
Actually, in the maternal
Is
medicine,
routine
it
to
is
do
done that at
serial growth
28 weeks
scans?
you do assess. At least from 28 weeks you do assess, right?
Okay.
So you can
So,
simply say
in
you
all
can do
high-risk
the
pregnancies,
ultrasound to
we
see
have to
assess
do
the
serial
growth
growth.
of the baby. Yes, to assess the growth of the baby.
No, but in this typical scenario, there is no growth restriction or any complication of growth restriction. So in this also, we should do that.
I will tell you what happens
no
is
need to do that.
that you do at 28 weeks for the growth of the baby. Actually, whenever some bleeding episode occurs during the pregnancy, the chances of growth restriction occurs because, of course, the patient gets anemic, right? Yeah. So when it occurs, so you have to do the growth scan. At the moment, we won't say that it is a risk factor of von Willebrand disease, but if she bleeds, yes, it would become a risk factor. So this is not something which would make you fail if you say that. And if you miss that, even then it is not something which is going to make you fail, right? So this is not such a point. Speaking it or not speaking it, both you make you in that neutral position. All right?
Okay. Actually, my point is that for all high-risk pregnancies,
we can say that. Yes, we can always say
should we do serial growth scans,
yes,
even if it is not a complication?
Yes,
actually, that was
you
my
can
point.
say that. You can say that we will do the ultrasound to assess the growth of the baby.
Okay.
All right. Thank you very much.
Thank you. Thank you.
Thank you, Shaheen. Thank you very much. Okay. Any question regarding von Willebrand? Is it clear? Is it clear to all of you? So this is how it goes. Introduction, agenda, information gathering, and von Willebrand disease effects on the mother and the baby, antenatal care, intrapartum, postpartum, addressing concerns. Thank you, Dipti. Follow-up plan, PIS. Yes.
Dr. Sidra?
Yes, Dr. Sidra.
Dr. Sidra, there is one question actually where we are doing one disease effect as is this is a station of booking. So we have to talk about antenatal, intrapartum and postnatal care. We have to go through all these things. So when it comes about genetic testing, so what I was suggesting that we have to just touch that you need to have a genetic counselor to check your husband's status and how much is the chance of your baby.
Abir went in a little more detail of needle testing and telling complications. That was not required. Yes, that took her time. That was not
that's my point. My suggestion was also my suggestion was also that no need to go through in detail of this.
Yes, no, not required. You simply say because it can be passed to your babies, therefore it is suggested that you have your genetic counselor visit and the partner is tested. We will talk to you in detail. So that's it. Needle testing, even if you have to say that if you have to offer the needle testing to check the baby, don't go into detail of needle testing counseling. That's not required. Oh, no problem, Abir, no problem. Instrumental vaginal delivery in Adra. IVD is instrumental vaginal delivery, instrumental birth. Okay. All right. Thank you very much. See, Dr. Sabia, see Abir's emoji holding her head. No problem, Abir. Everything will be perfect. The mistakes we do today is not going to be repeated in exam, and that's the perfect thing. Okay? Right? Well done.
Actually, Abir is very enthusiastic.
Yes,
and I am very happy to have Abir in my group.
Seriously.
She is very regular and always whenever we ask, she comes immediately. And definitely
let me tell you that she is the first person to join. I always see in the group, she's the first person to join and always there. So I'm sure she's going to improve a lot. I'm sure. And Abir, I'm going to give that special attention, my dear. Anytime, anywhere you feel like you have to just call me or do a station or you think that I have to assess you individually, people who are more active and the people who want, who are working harder, I'm all available. All right. So don't worry. We have improved a lot and definitely we are going to improve more. All right, Abir? Well done, my dear. Well done. I'm all available for you. Okay. All right. So coming to the last station of the day and last station by the celebrity. Where are you, Doctor?
Wow.
Okay, Okay, let's do the station. Check your mic, please.
I'm jealous, Dr. Sidra. You said
Yeah?
celebrity to. I'm
Because of my
jealous. You
baby.
said celebrity to Atiya.
Because of my child.
Okay, yeah. So tell me, Dr. Athiya, internet is fine? Mic is working fine, yeah?
At the moment, it seems to be.
Okay, that's perfect. All right, so you're home, right? You're not at duty?
No, I'm at home. I took the off today.
Okay, that's perfect. So
But
unusually,
I was not here for 2 stations because I have an unexpected guest sitting in my guest room.
I hope they're gone. Or you're
No,
doing
they're still sitting there. I told them, I'm so sorry, I have to go and I come back in 20-25 minutes.
Okay, no problem. So just concentrate during the station on this and not on the tea trolley, huh? Okay?
No problem.
Yeah, so we work on the station.
Thank you
All
for
right.
the moral support you are always giving.
Okay, thank you very much, my dear. Thank you. So, yeah, Dr. Bindu, she's always like that. And you know, when we used to do part 2, Dr. Bindu, at times she used to scold me as well. You think of Dr. Sabia, so she's one person who can scold Sidra as well. You can expect anything from her. Okay, let's begin. Station number 8. Let's enjoy. Everybody get energetic. The best station coming over. Let's begin.
Yes, please, next slide. Yeah. Hello, I'm Dr. Rahman, one of the doctors in the antenatal clinic. May I confirm your name and age, please?
Yes, sir. Hi, doctor. Doctor, I'm Annie Roberts. I'm 23 years.
How would you like to be called?
Yeah, Annie is all right.
Okay, Annie, call me Atiya. I can see from your letter that you are 6 weeks into your pregnancy and you have one disease called pulmonary hypertension and you are taking 2 drugs, bosentan and warfarin. Is it so?
Yeah, exactly, doctor.
Okay, Anna, as I'm seeing you for the very first time, so I need to ask you questions and then to know more about you. Then together we will have a mutually agreed, safe, acceptable plan. How does it sound?
Yeah, that sounds perfect, yeah.
Okay, Anna. So tell me more about your condition.
Actually, I'm 6 weeks into my pregnancy. I was taking my mini pills, doctor. I don't know how this pregnancy occurred. It's an unplanned pregnancy. I was taking my mini pills regularly, but to tell you honestly that me and my partner, we are so happy after that. So we have accepted it wholeheartedly. I'm very happy about this pregnancy now.
Okay, right. Anna, what about your certain conditions? Like, are you feeling, how do you feel at the moment? Do you feel anytime breathless? Do you have to wake up in the night to catch the breath?
At the moment, I'm feeling the same as I was in without pregnancy.
And what about this pulmonary hypertension condition? Like when was you diagnosed? Since how long?
Yeah, I was actually, it's been around 7 years that I was diagnosed with this condition. And the problem initially was that I was a little more breathless in the beginning when my medications were not started. I have my heart functioning test very frequent and I'm connected to my heart doctor. So now he has put me on these medications. After that, I'm a little better. Though I have my nursing support at home and all the aid for my household, I don't do anything. I take rest more because I get breathless very often. So if I take rest and everything goes in the same schedule, I'm better, doctor.
Okay, so how much climbing the stairs you can?
Maybe four, 5.
Okay, right. And when was your last visit to the doctor?
Yeah, that was actually 2 weeks back. But at that time, I didn't know that I'm pregnant. So the doctor doesn't know about my pregnancy.
Okay. Right. No issues. We will just liaise with your medical specialist. Regarding your pregnancy, how your pregnancy have been up till so far?
No problem at all at the moment. I mean,
Any
I feel
vomiting?
No, nothing like that.
Okay. And regarding there is any swelling in the legs or in the body?
No.
Okay. I need to ask, like, do you have any other medical issues other than this pulmonary hypertension, like high pressure, like high sugars, like asthma?
No.
Ever developed clots of lead in the lung?
No.
Okay. Any issue of concerns in your family?
And not that I know of.
Okay. Other than these two medications, the Bosentan and the warfarin, are you taking any medication?
That's it. I've started my folic acid 1 week back.
Very nice. And what about any allergies that you are aware of?
I'm not allergic to anything, doctor.
Okay. Any surgeries in the tummy or down below?
No.
Right. A few intruding questions I need to ask. Do you smoke?
No, doctor.
Any alcohol?
No, I cannot afford to take actually.
Right. And any recreational drugs?
No.
Okay. Are you aware of your blood group?
That's A positive.
Right. In case the need arises, do you have any reservations for the blood transfusions?
No, that's all right.
Right. And are you aware of your height to weight ratio, the BMI?
22.
Right. And anything that you would like to add to the information that you have given?
No, that's all right. I would just like to know how the pregnancy would be and when the baby would be delivered and all these information. Yeah.
Sure, I will address all your concerns. Just one more thing. What do you do for your living? How is other than the nursing support, how is your partner in support at the home?
Yeah, I don't do anything because my health doesn't allow me. So I'm just a home carer, and that too, I cannot do much of my work. But otherwise, I stay at home. My partner, he earns well.
Right, very nice. Thank you very much for all this information, Anna. I would like to know, what do you understand from pulmonary hypertension?
Pulmonary hypertension, what I know is that it is a condition which affects in which the pressure in the lung vessels, they are more. Yeah.
Right. Very nice. Okay, you're perfectly okay with your definition about the pulmonary hypertension. Yes, it's a condition in which there is a high blood pressure in your vessels that supplies the lung, and it affects your heart, and sometimes it seriously affects your right heart, that puts you and your life at risk. And normally what happens in pregnancy, the heart need to work extra and need to pump extra blood to the baby and to the afterbirth, that puts you and your life more at risk. And I need to inform you, but I'm so sorry to tell you about it, that the heart failing, you maybe more than 50% in the pregnancy, that may even lead to death.
Sorry, doctor.
Are you getting me?
No, am I hearing it correct? I mean, you're saying that this is something for which it can cause my death?
Yes, I'm so sorry to inform you that this condition which you have is a really serious condition that can put you and your life at risk. For us, your life is more important and we want you to be safe. So we always recommend those with having pulmonary hypertension to have not to get pregnant, or if got pregnant, to terminate the pregnancy. I'm so sorry that after hearing that you're so happy about this news of pregnancy, I have to inform this risk.
How can you say that so easily, doctor? I mean, I'm not having any problem. I mean,
I can understand. I can see I can understand your concern. You're very valid. Whatever you choose to continue the pregnancy or not to keep the pregnancy, we will support you. But it's my duty to inform you the risk for you and your life, so that you can make an informed choices.
I mean, this is so strange. I mean, so what if I continue the pregnancy?
Yeah, if you will continue the pregnancy, we will support in every aspect you are. We will have your follow-up in our specialist. You will be looked after a group of doctors we call multidisciplinary team. We will liaise with your heart doctor. You will have more heart checkup. You will have more things done, like your checkup of blood pressure multiple times, more visits to the hospitals. And but your keeping the baby put you and your life at risk. And the baby also need to be monitored more. Are you getting me?
I am, yeah.
Okay. So regarding your condition, as the pregnancy continues, you will be looked after a consultant-led clinic, in which people of heart specialists, specialist midwife, specialist nurse, and the help which you are already having at the home, and our consultant of pregnancy will be taking care of you, and you will be taken care, and more heart scans for your health, and more checkups for the blood pressure will be done to keep you growing. And you, apart from the routine antenatal care which we give to all the women, like having a viral marker checking in the first trimester, booking visit, and doing Down syndrome screening in the first trimester, and in the first 3 months, and then doing an anomaly scan, which is to check the structural abnormality of the baby by 20 weeks. And then doing the regular follow-up scans for the baby to, as the expected, that baby may grow smaller than expected. Are you with me?
Yes, I am.
Okay. I know it's a very hard decision, and it's very difficult to cope up with this situation. Would you like someone to accompany you?
Now it's okay. I mean, we've discussed everything. I would like to discuss with my partner now what to do about the situation. We were so happy to have the baby. I don't know. Can I meet my heart doctor? Maybe he suggests something else.
Yeah, we will going to liaise with your doctor, and I will urgently refer you to your heart doctor, and I will urgently make an appointment with my consultant also. And I must inform you that everything is the medicines which you are taking, the 2 medicines like the warfarin and the bosentan, is also not without risk. Like the warfarin may cause some structural abnormalities in the babies of the bone, nose, hands, and feet, and heart also. Whereas bonestan is not safe in pregnancy. So I need to inform them that if you wish to continue the pregnancy, they will going to change it according to your condition. Continue taking the folic acid and just keep on eating these medicines. Don't stop them, just to keep you safe till the time you meet your doctor. Regarding your decision, whatever you choose will be you will be respected. This is a written information. And just I need to inform you that even termination of pregnancy carries a risk of death. Like 1 in 7 may die during the termination, but that is far more less than continuing the pregnancy. Especially during the delivery and within the first 10 days of delivery, the chances of dying with this heart condition is very high. I'm so sorry that I have to inform you all these news. Okay, Annie.
Thank you, doctor.
Hello. Yeah.
Okay,
I will. No, I was just. I'm so sorry. I did the station very badly.
No.
Yeah, I forgot to give the support in the start, which I just clicked in my mind in the last. I'm so sorry about it.
Actually, the news was coming without empathy. That was the biggest flaw in the station. Rest, everything was fine. Empathy was lacking, Athiya, especially when you were doing the that point of telling me it's such a big news that it can be termination. That came very abrupt, as if like, you know, that I know it earlier. It was some sort of a breaking bad news, yeah? Other than that, station wasn't bad. Other than that,
it was like I had to, must have been given in the chunks. I would have called someone
exactly.
that are you alone
and
today?
That was so
3 steps
rapid.
of DB and I forgot.
Yeah, so actually not doing the BBN was the biggest flaw because it was so rapid for me. I couldn't absorb it. So that's why I said, sorry, doctor, am I hearing it correctly? So a little preparation of the patient in this station is very important. You know, prepare her gradually. And moreover, the words like, I would suggest like the words like very nice, very nice, very nice. 3 times you spoke in the information gathering. Nothing is nice today because you're making her come to the ending of a pregnancy.
Right.
So we have to avoid those things which is making a happy atmosphere. From the beginning, we have to bring her to a sad thing, right?
Right.
Yeah.
Right.
Yeah.
Yeah, this was the session I haven't practiced.
No, no problem. No problem. Let me mute everyone. There's a mic unmute. Hold on.
Yeah, but still I should have been more better.
No, nothing to worry. We'll just work on those things. So yes, Dr. Sabia, how did Dr. Atia do?
Yeah, she did well, but only the things you mentioned. Only if she talk about some support and empathy, that's will complete the things, I think.
Exactly. Only empathy was missing, and not only I would
the
say.
Last, Dr. Sidra.
Sorry, what?
Because
don't keep me in the last.
Your guest,
okay,
your guest all took your empathy.
Yeah. So I would say, information gathering wasn't bad, though I will add few points. When I said that only four stairs I can catch up, she could have used that point in the explanation as well. Things were not bad, but in the entire station, if I have to grade empathy was nil. I won't even say 1, 2, 3, 4. Empathy was nil. So it was a very, I would say it was a bombardment on me of the information and not, making me get settled. So that was one thing for which I have a concern. Other than that, you handle the station well. You have that quality of handling the station well. That's not an issue, but empathy has to be there, not speeding up with the station. Let's begin. Introduction was all right. She was Annie. Somewhere in between, you started speaking her as Anna. So please see the name carefully, right? So Nadra says it's a difficult station. How can we tell the patient that she might die? I had the station in practice. It was really difficult. Nadra, what if I give you beautiful lines and you will get ready to end up the pregnancy? Yeah? What if I do the station and you get ready? Yes, doctor, I'm ready for ending up of the pregnancy. Okay, let's do that. No worries. Okay. So let me give the feedback first, then I'll give the lines. All right. Introduction, agenda, information gathering. Then coming to the pulmonary hypertension history, few points were lacking here. So when it came to the information gathering, few points regarding the congenital and the late onset. So Dr. Atia did ask me about when did it develop. So air hunger is one word in the cardiac patient you always have to need to ask. So do you feel air hunger specifically at night? Right? This is how you ask the cardiac patient about the dyspnea, right? Do you feel or do you have air hunger at night? Was it by birth or developed later? Do you experience breathing difficulty? May I know how many stairs you can climb with ease? Please write down this. You have to ask in the same manner. May I know how many stairs you can climb with ease? I said 4 to 5. I'll stay quiet at this point and you'll see what I'll do at the breaking bad news. Okay, you'll see. Now, when did you have your heart checkup last? How is the functioning of the heart? How is the control otherwise? Right, this would be my HOPI. Rest all the template would go the same, the medical, the surgical, the family and all, that would be same. But these 5 questions I would speak in any cardiac patient. Noted, everyone? The 5 questions are noted? Clear? Okay. Now
Dr. Sidra, can you repeat the questions, please?
Yeah, sure. The first is that do you have air hunger specifically at night? The condition onset asked like, was it by birth or developed later? Do you generally have breathing difficulty? May I know any? How many stairs you can climb with ease? When was your heart functioning test done? And how was the result? I'm asking about the echo, okay? Clear, everyone? The 5 questions in the heart patient which you have to ask?
Why do I stress upon climbing stairs? And I was very happy when Atiya asked this question. See, never ask, like students, they ask me that, can you do your household work easily? So my household work, again, would be different from that of Atiya's, that of Dr. Sabia's. Dr. Sabia's would be different from that of Dr. Bindu. I always tell students that there's one day when I perform 5 hysterectomies and one day I do 5 mocks. So both the days are very busy for me. Both the days are very busy for me, but there's a difference in exertion. Am I right? Entirely busy days, both in terms of time are very busy, but one is like a little exertion and the other is a little like sitting and doing the mock. So one is mental exertion and the other is physical exertion. So there's a difference. You can never measure in terms of the domestic or the household work. Am I clear? So never ask this question, can you do your daily routine work easily? Because that cannot quantify the breathlessness. Am I clear? Please be active in the chat box so that I can understand myself that whatever I'm saying, you people are absorbing that. Clear? So these are the 5 questions which you people have to ask. Number 1. So when she says 4 to 5 stairs, I would understand that where I have to catch her later. Then I'll complete my information gathering, right? Hold on, guys. Okay. So when I'll complete the information gathering, the patient safety was that yes, it is unsafe to continue with the pregnancy. The idea behind Atiya's statements was fine, but the words which I would avoid in exam is that it is my duty to tell you, right? I would avoid that. I would avoid that by saying certain things like, this is how it is, and without breaking bad news. The patient safety was, it is whatever drugs she's taking is teratogenic drugs. I would, these are the patient safety which was mentioned by Dr. Atiya, that was very good. I would not say that these, how do we say teratogenic drugs? My way of saying that would be, these are not baby-friendly drugs and can cause complication, that's it. Would not go into detail what warfarin caused because itself now, we are at the agenda of continuing or ending up a pregnancy. So these are not baby-safe drugs, right? Long-term contraception is one patient safety which was missed by Dr. Atiya. Why? Because it's a contraindication to get pregnant. So are mini pills the safe thing which she's taking? And that too with bosentan and warfarin. Bosentan is an enzyme inducer. That's the reason she's pregnant today. So in the end, we have to tell you that because of this safety or the efficacy of this mini pill, it is suggested that either the tubes are blocked for this patient or we do some long-term contraception rather than ending up into this unwanted, unplanned pregnancy in an emergency situation. This was missed by Dr. Atiya. The third thing is surrogacy and adoption. That is very important. Remember, if you don't show her some path in future, she would never be ready to end up the pregnancy. Always remember that. This is a patient safety. Now I will do the management plan for this patient and I will tell you that how the things would go. I would tell her in this case that I will take the information gathering and will make some scenario to bring her to this position. Would say that, may I know, are you aware what this condition means? Please listen to the voice note and the words which I'm speaking and the tone and the pauses I'm taking. Don't rush to the station as like Dr. Atiya was having a rapid speed. Okay, here you need to take pauses. So may I know that what understanding do you have regarding your condition? I can understand that you're very happy with the pregnancy. I can see that you're here alone today. I need to talk something really important that will be difficult, that might not sound comfortable to you. I'm afraid I have a bad news for you. Can I proceed? Would you like somebody to be with you? The condition you're having, the pulmonary hypertension, in which high blood pressure is in the lung vessels, that puts an extra load on the right side of the heart. With time, the muscles of the heart, they become weaker. I'm afraid With this situation, we always suggest that the pregnancy should not occur at all, because the risk of death in these patients is around 40 in 100 women. I would just like to ask you, how would you feel if somebody asks you to climb 100 stairs in a go? Now I will take a pause. She would understand that she cannot climb more than 4 stairs. How would she feel climbing 100 stairs in one go? She would be saying, no, doctor, I cannot do that. Am I right? This would be immediate response. No, doctor, 100 stairs? What are you talking about? I cannot do that. My answer would be, this is what pregnancy means to your heart, Annie. Got that? Did you people understand that how I'm going to handle the situation? Where is Nadra? Nadra, did you get that? That how I'm going to use that flight of stairs and here at this point. How would you feel? Somebody asks you to climb 100 stairs in one go. Doctor, I cannot do that. This is what pregnancy means to your heart, Annie. I know this is very hard. I know this is very tough. That is the reason we suggest that either the tubes should be blocked for these women, or they should take some long-term contraception so that they don't end up into this complicated situation. Now we've got 2 options, Annie. Can I proceed? One is that we end up this pregnancy, which is the suggested option, and the other is that we continue with this pregnancy. Let me tell you that both these options are not safe. Let me be very open and honest to you. However, out of 2 unsafe options, ending up of pregnancy is relatively safer. We have got 2 options, the medical and through the surgery. Again, giving the anesthesia is risky in this case, for which anesthesia doctor will talk to you. Giving the mini labor, again, is not safe. My consultant will talk to you about that. However, earlier it is performed, better it would be. How do you feel about that? I know it's hard. I know it's tough. I would tell you that if we continue this pregnancy, it would be a joint team of doctors with my consultant, with a specialized midwife, with a heart doctor, with an intensive specialist, and an anesthesia doctor as well. But the first thing which I would like to tell you and emphasize upon the fact is that the medicines you're taking are not baby friendly. They can cause complication in the baby as well. But at the same time, stopping these medicines can worsen your condition as well, as you realize yourself that you had breathlessness when these medicines were not started. Therefore, it's a very complicated situation, either to stop or change medicines or to continue with pregnancy and having abnormalities in the baby. I hope you can understand the situation. Therefore, we suggest that ending up of the pregnancy is the safer option. If at all you want to continue, you'll have frequent visits and more chances of hospitalization, the chances of clot formation, having complication. If at all we move forward without complication, the chances of cesarean are also on a rise. But the experience which we have is that patients, they don't reach up to the due date of pregnancy, ending of labor. They have to be delivered earlier because of complication to their health. Again, I would suggest that ending of pregnancy is always a better choice. I can understand that it's a very difficult situation at this point in time, Annie. But we have other options. I appreciate that the feeling of motherhood is making you cheerful at the moment. I would like to tell you that for these women, after ending up of this pregnancy, we are here to give you a plan that you can have kids, you can enjoy your motherhood. We can hire a womb using your eggs, meeting up with your partner's sperm and placing it to a woman for 9 months. And this is legally your baby. Or else we have an option of adoption as well. I would suggest that after ending up of this pregnancy, we use some long-term contraception with better results so that you don't end up into this situation again. How do you feel about this now? Friends,
Would you be able to understand in this situation the way I have explained that if you're not going to give her the option of surrogacy adoption, she would not have that future feeling. Now she is not ready for the termination. She is not ready for the termination. Why? Because she has a hope of having a child. So if you give her that after ending up, what would be the hope? She would understand that what is important in the termination. Right? This is how I would do the station, and believe me, she would be ready for the termination. Why? Because I'm telling her the future prospects. I'm telling her that she can be mother. The biggest problem in this station is that she wants to enjoy motherhood now. She has that feeling of, having a child now. So we have to deal with this. But did you notice I gave this animation specifically? Did you notice the sequence? I worked on this animation specifically. Working of termination first, telling about continuation of pregnancy first, telling how termination would be. And did you notice my sequence? And did you notice that sentence which I'll speak to my patient? Any out of 2 unsafe options, this is relatively safer. Did you people notice this sentence of mine? Out of 2 unsafe options, this is relatively safer. Yeah? So this is how you have to speak. After continuation of pregnancy, come back to termination again. And then tell her that we have got future prospects. We appreciate her feeling of enjoying the motherhood. And we are here to support her for future. But for now, this is the safer option. Now, if I say that I need a little time to talk to my partner, I would say, I appreciate that again, Annie. However, I would suggest that earlier you take your decision. Lesser is the duration of the pregnancy, better it is to decrease the workload on your heart. I hope you understand. So now, exactly, Jyoti, well done. So now you understand, we can't say, Dr. Athiya said the same things. She said that 7 out of 100 is the chance, which is less than 40 out of 100. So what am I saying? I'm saying out of 2 unsafe options, yes, this is the safer option as compared to that. So please note down these words. It took me lots of time to solve the station. I solved it for the last batch. It was around 6 months back when I was given a task by one of my Egyptian students, very close to my heart. She has passed this exam now, and she's working there, in fact, doing her local clinic there, working as an MRCOG. She requested me that I'm having lots of difficulty. At that time, I was not doing these group classes. I was only doing a single station as in one-to-one. So I solved the station for her, thinking about the lines, how I can be empathetic. So now this is how, this didn't come in my exam. This station didn't come in my exam. But students who had this in exam, they had real difficulty. Exactly. I'm all available, Dr. Bindu, no problem at all. This is something which comes with practice. I was not born with this, but yes, it was my strength from the beginning. I mean, I've always been on the rostrum and on the mics since my school days. This works now, but still it comes with improvement. So please be empathetic. My idea of doing this was that I tell you the difference between all these points. All these points, Dr. Bindu, were mentioned by Dr. Athiya as well. But the way was different. She was very rapid in her, and I was like taken aback. You people have to take pauses, please. Understand her situation. And I think the heart-winning line would be when you tell her that, how would you feel if somebody asks you to climb 100 stairs? She would be like, oh my God, doctor, I can't do that. This is the best understanding a patient can have if you tell her as a pulmonary hypertension what pregnancy means to her. What pregnancy means to her, this is the best understanding. She would never understand if you tell her that the blood goes from here to here and the right side pumps and this goes here and the pressure is rising. But physically, when you'll ask her, please climb these 100 stairs, she would be like, no, doctor, I can't do that. Am I right? Am I right? Thank you very much. So this is how it goes with the outline, please. Introduction, agenda, and information gathering. Please go with the termination first and then take her through this and come back to the termination. Address her concerns. Ask her to come back quickly with a decision. This is your patient safety. It's not that she goes back and she returns maybe after 10 weeks. Every passing week increases the workload on the heart. So this is your patient safety as well. All right, friends. So Nadra, now tell me that this Thank you very much. Thank you, Nadra. I'm really grateful. Now it would be easier. When you people were doing in the mini groups, I understood that this station would be difficult, but I'm happy now that the things are easier. You people do this revision and you people make a difference in your presentation. I'm the happiest person, believe me. Thank you very much, friends. Thank you. So done with 8 stations a day, a long day. I think you people would be tired. Thank you very much for a wonderful discussion. Next session would be on core surgical skills and post-operative care after 2 weeks' time. But this time after 2 weeks, it would be Friday, right? So skipping up the next Friday, next to the next Friday, it's going to be the core surgical skills. Is it all right after 2 weeks? Yeah, friends? Fortnightly session, all right? Give me a thumbs up if it's okay. Friday after 2 weeks' time. Yes? Very good. Well done. So I will be posting the topics today and the WhatsApp tasks as well. Core surgical skills, post-operative care, basic template. I'll tell you what is the difference between the general things and here. Go with the introduction, agenda, history of presenting illness, details of the complaints, example pain, fever, breathlessness, operation details, any treatment taken so far. Gynae history, obstetric history relevant, please take. If she is uncomfortable, she's in emergency, she needs a painkiller, medicine, vomiting, oxygen, please settle her first and then take a pause and ask her, are you okay for me to continue? Are you okay to talk to me now? And then seek permission and start with the agenda, okay? Surgical history, family history, drugs, personal history. Any concerns regarding the blood transfusion, always ask in the surgical module because there can be a hidden agenda of Jehovah's Witness. BMI, smoking, alcohol, recreational drugs. And remember that smoking, alcohol, recreational drugs, social and mental health, these extra questions in emergency, avoid that. If it's a plain surgical case, go for that. But if it's something like in which she's having breathlessness, like an pulmonary embolism or like that of an intra-abdominal bleed, then please don't ask about the smoking, alcohol, or recreational drugs, or how are things at home and how do you feel in the last 2 weeks. She would be like, doctor, I'm dying, please. So that's why I've made a block. Skip these questions in an emergency situation. Am I clear? In an emergency situation, skip these questions of your template. Yeah, 2 more things. Sorry for Dr. Athiya. I think Dr. Athiya has left because of her guest. Dr. Athiya, when you listen to the recording, please, 2 things I had to mention, which I had written. Don't signpost intruding questions between smoking and alcohol, please. I've written that for you. And number 2 thing is avoid very nice things in the BBN station. And number 3 thing, which I've written is that call me Athiya. In the beginning, avoid that. I know in many telegrams, people, they're saying that, but this is something extra. So it's better that you avoid this thing. So these 3 things I've noted specifically for you. Please avoid these things, okay? When you listen to the recording, you'll get these 3 points. Thank you. Okay, so BBN in the case of complication, always remember when complication has occurred, do a breaking bad news. Please do signposting. In management of surgical module in a complication, do the emergency management, stabilize the patient, and according to the cause, specific management would be there. Please don't say thank you. Don't say bye-bye. See you later in 2 weeks' time or 1 week time. Any patient who is in a complication, please. Always say, I'm here to take care of you in this situation. So when the bell rings, please show your availability to the patient, right? Yeah, exactly. It's not required, Jyoti. And specifically for exam, it's not required. In many Telegram, many Arabic mentors, they do that, I know. And I know when you listen to multiple of the people speaking, you try to get like many things from there. So it's better that you simply ask her, how does she want to be addressed? That's it. So they should know, it's an extra sentence which you are speaking, so we should avoid that, okay? All right. Now, some important buzzwords for passing this module, which you must ensure that you have spoken in these stations is consent, Girija, WHO checklist, enhanced recovery program, incident report, risk management team. And remember, if she's angry, patient advised liaison service. Examiner loves these 5 words specifically for this module, please. Always ensure that we'll talk to you prior to the procedure, consent. We will do the specialized checklist, safety checklist for you. We will ensure that we follow the safety program, early recovery program for you. Initiate incident report. The team of doctors will look into the matter and we'll be open, honest, and transparent about the report. And if she's angry, connect her to the patient advised liaison service so that she can launch her complaint. Now, again, for the complaints, remember, if vomiting is there, always think of bowel. Why I've written bowel here and bowel here without E and with E. In exam, you enter into the cubicle and there's a bowel on the table. Remember that this gives you a hint that patient is going to vomit. This happened with me in our COT course. They keep a bowel on the table that tells you, okay, you're going to talk to the patient and she'll start like doing, okay, she starts vomiting. So remember that this bowel is related to bowel injury, okay? Flank pain is for ureteric injury. Decreased urine output is the buzzword either for the bladder or for the ureter. Hypotension, if they give in the question, they give you bleeding or hematoma. And address all differential diagnosis if you're not having a definitive diagnosis in the question. So this is my hint for you guys, because in many stations it gets a problem, right? Thank you very much. Any questions, please? I'm here to answer. We'll be posting all the next things after 3 to 4 hours. We'll be posting after conversion this recording onto your Google Drives as well. All right? Yes, my dear. Any question? Yes, my dear, please.
So is the plan now to do 2 weekly modules?
I think this is what maximum people agree to. You people want another 1 week, 3 weeks?
I don't know. Yeah, I think that would be good. But yeah, of course, we want not to lose touch in between. But
yeah, because see, Jyoti, exam, if it's in February, and if you finish up your exam stations around with this pace, we'll be finishing up around in October, November. So then you'll be shifting to books.
Okay. So to books means we do with you or we do on our own?
What other batches are doing? At the moment, they're not having live sessions because that's another course, of course. But April batch, what they've done is I've made a get through schedule for them. In the mini groups they're doing, they're making their templates, and in the mini groups I keep them active. Live sessions are not there, of course, but I have made a schedule for them. Page number, batch number, everybody is making template and they're doing together. But at least I'm keeping them active. So they've started their books. I've made a schedule complete. Schedule day wise that what station they have to do. So they're doing on their own, but they send me the voice notes of when they were stuck up, so that my supervision is there basically.
Yeah, but the exam in February is also not sure. Like we don't know, but we will know probably by November.
I think, yeah, in 2 months time we would be clear. Once the November exam would be done, we'll be in a better position.
Yeah, if there is any exam in February, we will know in November.
Yeah, definitely.
What my request would be that if the gap is big, then can we do a revision towards the end, like when 1 month is left, maybe 15 days before the exam, can we have 2 weeks of something active with you?
I'm all available once this course would be over. Anything you people would be wanting that, or if you people would desire that, would definitely we can consider that, no problem. Okay.
Okay.
Okay. Thank you very much. Thank you. So 2
weeks chance of
okay.
Getting shifted to another batch.
Sorry. Yeah.
Is there any chance for us to be shifted to the next next batches?
Jyoti, it's not possible for the reason that I've given you guys stations, right? So it becomes really difficult for this reason. That's what I told Girija as well. Because see, people have utilized, if it would have been at start, so everybody is continuing with the same. And even in the continue, like Dr. Bindu, she has just written in the chat box, like 2 weeks are okay. If I give you more than 2 weeks, then it would be very, I think you people would become slower. So I think
we are doing something throughout, like if we are doing some books or other things, and if we are
everything would be
1 month before, then 2 weeks can be okay.
Okay, yeah, right. So because you have to cover lots of stations from the books as well. I mean, you people for the curriculum, right? At the moment you're doing only books, but then curriculum is way too large, Jyoti. So you have to complete that, right? Okay. Thank you very much. Any other questions, please, regarding the maternal medicine? Done? Clear? Where are the participants? Abir, Archana, Dipti, Dua, Bindu, Girija, Harshima, Nadra, Sabiha, Sarva, Shaheen. So thank you very much for energetic and wonderful discussion today. After 2 weeks, we'll start the surgical module. I'll post the stations just now so that you people can distribute, and the WhatsApp tasks as well. Until then, please take care of yourself. I'm not doing the group assessment just because now the days are more, so I cannot make the graph, because few days you people meet, few days you people don't meet. And that's understandable because exam is delayed. So keep going, my dear. 1 station a day, it should be done so that you people keep on moving. So take very good care of yourself, please, and stay in touch in the mini groups and keep me updated with your progress, right? Until then, let's revise the topics from the maternal medicine tomorrow or day after tomorrow. For 2 days, you can complete your templates from this. And after that, you can start your surgical module. All right? Thank you very much. Thank you. See you guys after 2 weeks time. Until then, we will meet in the mini groups on and off. All right? Thank you very much. Have a good night. Stay blessed. Okay. Bye-bye from my side. Thank you.